conducting the scientific programs for postgraduates. So this is also one of the programs. So I thank MPMRT, also MPMRT member. So program will be in live stream today. Actually, it was not planned, so we did in a short time. Tomorrow also will streamline the clinical care discussions. Thank you.
So we have a doctor. I think should be a practice. So the name of the doctor. So that means I'm very practice. I think we understand.
Good afternoon, everyone. Here is a Mr. A, a 41-year-old male patient who has studied till 7th grade, is a butcher by occupation, and is left-handed. He presented with complaints of sudden onset giddiness, complaints of change in voice, complaints of sudden onset giddiness, complaints of change in voice, complaints of swaying to the right side while walking, complaints of drooping of right upper lid, and complaints of difficulty swallowing, all since 6 days. Patient was apparently normal 6 days prior to the admission, when on the day of
we have majority of them with right hand. So if one is patient is left hand, right?
Yes, sir.
He is a left hand. If patient has a neurological problem and is a left hand.
Potentially from a diabetic.
In left hander.
Sir, dominance is also right dominance, sir. Right dominance is present in 60% of patients. 15% have left dominance and 15% have mixed dominance.
Afternoon,
Patient was apparently normal until 6 days back, when on the day of onset, he woke up at his usual time around 3 a.m. to attend to his work as a butcher. He was well for...
Those who are here, don't open the link. So, WhatsApp. You have sent for the postgraduates. You open the echo link.
Patient woke up at his usual time, which is around 3 a.m. to attend to his work as a butcher. He was well for about 1 hour. After this, he developed sudden onset giddiness, which he described as spinning sensation of the surrounding. This was associated with complaints of nausea, no complaints of tinnitus or hearing loss. Patient did not have any postural variation or aggravating symptoms on sudden head turns. He then drank tea, during which he had no difficulty swallowing. After this, he lied down to rest, and after about 1 hour, which is around 5 a.m., he developed excessive sweating, which was not associated with chest pain or palpitation. He had 2 episodes of vomiting, which was clear yellowish in color, non-bilious, non-food containing, watery. His wife then gave him water to drink, which he was unable to swallow and subsequently coughed out. He was taken to KR Hospital. He was taken to KRPT Government Hospital. At that time, patient had no complaints of loss of balance, swaying, or weakness, and was able to walk to the hospital without requiring support. He was treated there symptomatically and was sent back home. On his way back, which is around 6:30 a.m., his attendants noticed change in his voice characterized by hoarseness. Because of no symptomatic relief and persistent giddiness, he was brought to JSS Hospital. On arrival to JSS, while getting down the vehicle, he noticed difficulty in maintaining balance while walking, with tendency to sway and fall towards right side, requiring attendants to support him and bring him inside the hospital. His attendants also noticed drooping of his right upper eyelid, with patient persistently looking towards his right side. He was then admitted to hospital for further care and management. There was no history of weakness of upper limb or lower limb, such that patient had no difficulty in lifting objects or gripping of objects, standing or walking due to loss of his power. Patient was able to sense clothes over his body. There was no history of numbness, tingling sensation, or burning sensation. There was no history of difficulty understanding speech or inability to express speech. No history of difficulty in recognizing familiar people or objects. There was no history of memory disturbance or difficulty recalling events. No history of diminution of vision, blurring vision, or visual field defect. No history of double vision or difficulty in eye movements. No history of loss of sensation over his face or facial pain. There was no history of facial deviation, inability to close the eyes, or drooling of saliva. No history of slurring of speech or dysarthria. No history of difficulty in lifting his shoulder or turning the head. No hearing difficulty. No history of headache, altered sensorium, seizures or confusion. No history of loss of consciousness. No history of chest pain or palpitation. No history of recent neck trauma or sudden neck movements. No history of prolonged immobilization. No history of fever, rash, joint pain, or oral ulcers. No history of any recreational drug use or toxin exposure. Patient is not a known case of any comorbidities like hypertension, diabetes, dyslipidemia, or heart disease. Past history. There is no history of similar complaints or episodes suggestive of TIA in the past. There is no past surgical history or no past malignancy history. Personal history. Patient's appetite is normal with predominantly being non-vegetarian diet. Regular bowel and bladder movements. Sleep is adequate and undisturbed. He's a chronic smoker, smokes 1 pack daily per day since 20 years, and he has abstained from alcohol. His last drink was 1 year ago. There is no significant family history present. To summarize, Mr. A, a 41-year-old left-handed male, butcher by occupation, with history of chronic BD smoking and no known comorbidities, presented with sudden onset giddiness in 60s with dysphagia and dysphonia, and difficulty maintaining balance while walking with tendency to sway towards the right side, with drooping of right upper eyelid and right gaze preference. He initially sought treatment at local hospital and was later brought to JSS in view of persisting symptoms for further evaluation and management.
Now you go back, try to evaluate the symptoms. So first thing is to analyze the symptoms first. So how do you consider, how do you evaluate the symptoms?
So his first symptom was giddiness.
Say it was an acute event. Okay, acute onset of neurological illness. So most likely it should be either it could be a vascular or a traumatic.
Yes, sir.
Right. So based on the timelines, we divide them into acute, subacute, or chronic. Here it typically fits into 2 hours.
Yes, sir.
Right. Suggesting that's it. Acute neurological illness. Fine. Okay.
So his first symptom was giddiness, sir. To rule out if it was a peripheral cause or central cause of giddiness, he did not have any associated complaints of tinnitus.
See, giddiness now, it is not peripheral or central. Okay, giddiness is a symptom, is a vague symptomatology, which has got so many parameters. So actually, was it a giddiness? Was it a presyncope? Okay, was it an actual TIA? Was it an occipital infarct that is coming? Okay, is it an occipital TIA that is coming? Or is it a presyncope, absence seizures, atonic falls, okay, drop attacks? These are the differential diagnosis for a giddiness.
But yeah, Harrison mentions that way. So you cannot just, giddiness is like quite a vague symptom. Okay, it can be dizziness, it can be swaying, it can be unsteadiness, it can be ataxia. Okay, it can be vertigo. Okay, so what symptom here?
So
then
patient
which is labeled it as that, then you can say it's a central
Yes.
or
So patient
whether it's syncope.
has vertigo, sir, because he has.
Okay, one more point. See, you have taken a complete history. So at the end of history, the first thing to be noticed now, which system is disease here? The first system disease is nervous system. So in the nervous system disorder, you have got a approach. Approach is one, the system disorder is nervous system. Second, what is the type of the neurological disease? Sir was saying that. What is the type of neurological disease? Since it is an acute onset of a focal neurological deficit attributable to a vascular cause, you consider it as a cerebrovascular disease. If it is a cerebrovascular disease, next question, is it an anterior circulatory or a posterior circulatory? So how do you distinguish an anterior circulatory from a posterior circulatory? The answer is the posterior circulatory symptom will have usually bilaterality of symptoms, unsteadiness, and element type of lower cranial palsies. Unilaterality of symptoms, uniocular vision loss, aphasia is more in favor of anterior circulation. So here it is going for a posterior circulation state. Next one, sir was saying you analyze each symptom. So your first symptom is vertigo. Your second symptom is unsteadiness while walking. Third symptom you told regarding some difficulty in swallowing. Okay, then some drooping of eyelids. Then if you turn back your just next slide, you have certain things you can avoid, like gaze preference. The patient will not say like a gaze preference. Okay, gaze, he prefers to look to gaze preference is actually terminology.
Yes, sir.
Then you told in the negative state there is no dysarthria.
Yes, sir.
Okay, but now patient was having hoarseness of voice. No?
Yes, sir.
So that definitely the patient will have some dysarthria because of, so if you are having a difficulty in swallowing, definitely there will be dysarthria. So if you say certain comments in the history, when you say negative state, it should not, it should go always hand in hand. Okay.
And one more thing is, as far as possible, they use patient numbers. No, don't use your terminologies when you are narrating the history. Okay, case preference. Okay, these things should not be used. It should be in patient's own words. Right?
So actually,
I
the guy
agree.
told that he was looking towards right side, sir. In summary.
Okay, okay. Then
Yeah,
you
and
can say
you
he
can anything better, you can use that.
Yes, sir.
Right?
he
I'm saying
prefers
that
to
it's
towards.
okay. So when you are evaluating it is,
Yes, sir.
now you say you feel that's what I
Vertigo, sir.
okay.
Because he has sensation of the spinning of the surroundings, sir. And now I would want to differentiate if it is a central cause or a peripheral cause. For a central cause, for peripheral cause, I would have associated symptoms like ringing sensation in the ear or hearing loss, which the patient did not have. Other than that, peripheral vertigo is intermittent, which is usually associated with aggravating factors like sudden postural changes, whereas central vertigo is persistent. Since patient had continuous symptoms with no relieving factor,
Which one is more severe, central or peripheral?
peripheral is more severe,
More
sir.
And it will be associated with nausea and vomiting. So your patient was having more of nausea, vomiting.
Yes, sir.
So do you want to consider it as peripheral or central?
Central, sir.
Okay, usually central will have milder symptoms. It may not be much a symptom, but presence of long track symptomatologies with vertigo is more in favor of a central. That's the point that you can take down from. Okay, so there are other neurological symptomatologies. Since it is there, you can consider it as a central vertigo. Okay. So after that central vertigo has subsided, the patient started developing unsteadiness while walking.
Yes.
So how do you approach to an unsteady gait? What are the 6 cardinal determinants for normal stance and gait? So did you rule out each of that in that history to know whether it is a, what sort of a unsteadiness is it? What are the normal?
Got the mission. Okay.
What are the normal 6 cardinal determinants for normal stance and walk? One is the pyramidal, second is extrapyramidal, third is cerebellum, cerebellum. Then it is posterior column,
Yes, sir.
then
Vibration.
vision and equilibrium.
Yes.
Okay, so your patient might have had unsteadiness either because of equilibrium problem,
Yes, sir.
or it may be because of a sensory ataxia. But so your history may say because it was towards the evening hours. So was it because of a unsteadiness of gait while no patient is towards the evening hours, while he closes eyes, he's becoming more swayed, or is it because of a tripping of toes, difficulty in holding of a pyramidal, or is it because of a basal ganglia, extrapyramidal? Okay, or is it because of a cerebellum? So what are cerebellar symptomatologies you could have much more asked to know whether it's a cerebellum?
So first is because patient did not have any weakness, sir, that is ruling out any pyramidal cause of his gait disturbance. Second thing is patient was able to feel clothes over his body, which ruled out any sensory component involvement. We are left out with vestibular component and cerebral component. Both are to be considered at this point of history, sir.
So if it is cerebellum, you could have asked a little bit more symptoms. What are
Tremors.
such symptoms? No? What is the symptoms are dysynergistic symptoms. That means, is there any decomposition of movements? Is there any hypermetric movements? If he is trying to catch hold of an object, is he underreaching or overreaching? Is he having any tremor while he is moving the hands? Is he still feel unsteady? No.
Actually, sir, during the course of hospital,
Yeah.
wife told that she noticed patient overreaching the object, sir.
Yes.
This was
So-
in the course.
okay, so
No. Analyzing the history, see when patient says that patient has ataxia,
Yes, sir.
okay, you should be in a position to tell what could be the cause for the okay, whether patient had any evidence of vestibular vestibular disturbance, or is it because of ocular visual disturbances, or is it because of cerebellar dysfunction, or is it because of pyramidal,
Yes.
apart from posterior columns.
Yes, sir. Because wife gave history of overreaching for the object, sir. That
so
again
the
is
state
the
understood it is cerebellum.
cerebellar involvement.
So we understood it's cerebellum. Was he walking with a wide base? Was making a sudden turn? If you had such more symptomatology, then the exam will feel you are dealing with a peculiar cerebellum.
And you need to say whether it was one of the cerebellum,
Yes.
Or how do you?
So also patient had swaying towards the right side, sir, which points towards unilateral involvement.
What happens to the gait if patient has unilateral cerebral involvement? What happens to the gait if patient has bilateral?
Sir, there's ataxic gait, sir, if there's cerebral involvement.
Where?
Towards the
Usually
right.
get an ataxic gait. The ataxic gait is called a wheeling gait, otherwise called as drunken gait. Where a patient walks to one side, that's where it typically occurs when there is one side in the cerebrum. If patient has bilateral cerebral involvement, as you get in OPCA, cerebralitis, cerebral atrophy, you will get a wide-based gait, wide-based stance as well as wide-based gait. That's one thing which will help you in distinguishing. Here, patient was walking to one side.
Yes.
Clearly tells you that it was involved of one half of the cerebrum, right?
If you consider it as cerebellum, is it a cerebellar hemisphere involvement? Is it a peduncle or is it a tract or is it a vermis? You told it is ataxia. So is your symptomatology is in par with a hemisphere symptomatology, a peduncle, a tract, or is it a vermis? How do you distinguish?
Sir, again, because of associated symptoms, sir, because of
What will be the typical cases if it is a vermis lesions?
Sir, first is there is no truncal ataxia, sir, which
Okay.
rules out.
Truncal and
So in your history, you should definitely mention your while sitting, slow and steady. So vermis is out. So do you think it is hemisphere? Appendicular symptomatologies are more for hemisphere. Now, if the patient is having ipsilateral cranial palsy, long trunk signs, symptomatologies, it is more in favor of peduncle. So the possibility here could be either a peduncle or a hemisphere.
right?
So next symptom.
So after this, drooping of
Difficulty-
right upper eyelid.
Okay. So-
Difficulty swallowing, sir, for liquids.
Okay, so what is your approach to that? Difficulty in swallowing, what is your approach?
Sir, first is I would want to know which phase of deglutition is involved, sir. This is looking like pharyngeal phase of deglutition. This again, I would want to look for because patient has been given liquid, sir, that is ruling and had difficulty swallowing liquid, that is ruling out any surgical causes like compression.
Let's see. If a person is having a difficulty in swallowing, it is given written esophageal dysphagia, which is mechanical. Next is called neurological dysphagia, which is the oropharyngeal phase. So the oropharyngeal dysphagia means the early part of deglutition is affected,
Yes.
which will be both for liquids as well as solids. That means it is a neurological. So you should say while the patient was given feeds, either drinks or some feeds, patient had choking, difficulty to swallow, even the saliva was very difficult to swallow, and he always used a cup to spit out the saliva. That clearly indicates
History of nasal registration. That again adds up to that.
Okay, if there is, okay, so if it is the later part of deglutition is affected, tightness in chest is a mechanical, which will be more for solids. So your history should point out these. So the approach is the most important thing rather than telling a diagnosis. So
Can there be neurological cause of dysphagia in lower end of sickness?
Yes, sir, because of the intrinsic, there are two
Sir is
types.
asking a very definitive question. Neurological cause of dysphagia.
So that the lower end.
Or
Usually
black
apparent
plexus,
dispute.
or black plexus, sir, if that is involved.
Which
Achalasia cardia.
The symptoms will be totally different.
Yes, sir.
the oropharyngeal dysphagia is again divided into LM.
Yes, sir.
If it is more of a nasal regurgitation, that is indicating that it is an upper motor neuron type of palate. So this patient, do you think it is a UMN or is it LM? Because in LMN, the palate will not move.
Yes.
So the swallowing may not happen. It is upper motor neuron. There may be, one part may involve. So there may be more of a nasal regurgitation. So was it, you might have seen some talks where the patient complains more of nasal regurgitation, whereas in an element palate, they will go on spitting. So there is a difference. So was it a nasal regurgitation more predominant?
Sir, actually, to differentiate between human and element, patient should have any emotional lability, sir.
No, that's a supranuclear. This is acute. This is acute. It's a very different entity. That's again will have definitive dysphagia.
Sir gave a different example. Say, for example, patient has a poor element. Say, for example, patient has bulbar palsy, acute bulbar. And patient has difficulty in swallowing, so patient keeps spitting out repeatedly. If patient has a picture suggestive of 9th and 10th, then what happens? They tend to have more of nasal, they will have UMN symptoms. So patient will have more of nasal regurgitation and difficulty in swallowing. That become more pronounced. So you tend to distinguish with this.
So,
Okay.
so it can happen with the element the swallowing will be affected. Moreover, hoarseness of voice. Okay, is a point that favors it is. So from your difficulty in swallowing, you indicate that the person is narrated false. Yeah. Next symptom.
So next was again his wife noticed right drooping of upper eyelids, right upper eyelid. So third,
Mainly patient has all more of symptoms related to the base of the brain, but here it has the eyelid. So how do you come to that?
So there are two causes, sir. One is either sympathetic chain involvement or it can be because of oculomotor nerve involvement. Because
So
patient
how
did
do you
not,
distinguish oculomotor palsy from sympathetic nerve?
so he did not have any diplopia, sir.
No,
And patient did not.
oculomotor involvement invariably leads to total ptosis,
Yes.
complete ptosis. But in this one, patient will have partial ptosis.
See, in a complete ptosis, the patient will not have depression because one eye is closed only. And so when one eye is closed, okay, you say that eye is only partial. Even this patient may not even okay.
Password ಹೇಳಲ್ಲ NABL 030
Partial third.
ಇದಕ್ಕೆ ಹಾಕಿ ನಾವು ಸ್ಕ್ಯಾನ್ ಮಾಡ್ಕೊಳ್ಳೋಣ.
ಈ ಸತಿ ಕಾಕಕ್ಕೆ ಹೋಗ್ಬಿಡೋದು ಫ್ಲೋರ್ ಅಲ್ಲಿ NABL 030.
So during the course of the hospital, patient had had overreaching for the objects, sir. That was the only symptom which was
Here patient is
yes, sir.
And the patient is disappear.
Patient has dysarthria.
yeah. So what is your approach to?
So according to since all are pointing towards cranial nerve involvement, which is so main.
For that, no, you should first say the patient is able to understand what is being told and he is able to break meaningful words. So a speech abnormality that rules out, then it's a dysarthria. So is it a cerebellar dysarthria? Because now the patient can have a cerebellar dysarthria here. You can have an element dysarthria. Okay, so there are different other types of dysarthrias. In this scenario, these two are the important. So how do you distinguish between these?
Sir, in cerebral dysarthria, patient will have checkered to speech. So that means he will have
So by
splitting.
history, what they will do, they will decompose each words to scan. They will scan each words. Suppose there is a superimposed tremor on that. Let's check it. Okay. Then if you say element type of dysarthria, what are the three types and how do you ask the patient?
So first is flaccid paralysis, sir. Next is in flaccid paralysis, patient will have difficulty in
What
labial
are the
pronunciation
three
of words.
types of element dysarthrias?
So first is labial.
Yeah.
Second
What
is
are the phonemes used to know it is a labial dysarthria?
B M.
It is ma, pa, ma, pa.
Papa Mama is.
You know which? You know one of your famous person here in Mysore. His name was Muthaya Bhagavatam. He for the king, no, he wanted to sing a song, but at that time he couldn't sing because he had a bee sting at his mouth. So Muthaya Bhagavatam created a raga where he can't use mapa. You know that from only Mysore, no, it came. It is called Niroshta. Niroshta means nahi ushtam, means ushtam means lips. Na ushtam means no lips. So mapa. So by that you can understand mapa is for element facial parts. Okay. Next is guttural dysarthria. So which are the gutturals you use?
G.
Indian language are better. Remember is simply. The labials are PPBB, Papa Babama. Okay. Then they are labials. Then you have linguals. Linguals are Tata Dana. They use your tongue. Aha. They are gutturals.
So you can ask ka, ka, gha, gha, nga. Ka, ka. Okay. Then little, linguals. Okay. La, ta for hypoglossal. So you ask the patient whether the patient wife differentially notices any phonemic abnormality in articulating certain words like mapa, kaka, or lata. If you say clearly this, then examiner will understand your knowledge on the phonemic differentiation of the element types of dysarthrias. Okay. So with this, now all history. Next, now you told that the diagnosis first is the top. So your diagnosis here first now is the type of neurological disease. You told it is a cerebrovascular disease, posterior circulatory stroke.
Yes.
The next you have to say topography. What is the topography of presentation here?
So because
It's an ataxic syndrome because now the patient is presented with abdominal ataxia with cranial nerve syndrome. So your anatomical localization.
Brainstem involvement, sir, with
Okay, so-
plus minus cerebellar involvement.
No, from history, no, what all tracks are in one, definitely you can say cerebellar.
Yes, sir.
Okay, second is palatal palsy.
Yes, sir.
Then third, you presume to be what? The person presumes to be having a horns, so sympathetic trunk. Okay, these are the structures that are involved. No,
Yes, sir.
where are these structures located?
Sir,
This is located in the middle.
medulla, sir.
See how it's very easily. How can you identify these? When
Get involved.
This
Also
is
learning
about five. There's a
the brainstem. Then we get a rule of 4. What is the rule of 4? So four structures are definitely medial. It is one is the motor tract, that is the pyramidal tract. Second is medial lemniscus, which carries decisions. Then you have the medial angular fasciculus, which is more medial. Right? Okay. These typically are typically in the midline. Yeah. Then you have the spinocerebellar tract, the spinothalamic tract, the fifth nerve, this one, okay, which the tract of nerve, which is definitely on the lateral side. Right. And when you take the nuclei again, the last 4 nuclei are literally in the medulla. The next 4 are in the pons, and the last 4 are above the pons. So this is what is called as the rule of 4. If you use in neurology, yeah, definitely it makes it simpler to analyze where which structures are. Yes.
see, there is a very simple method which I say always for LP school. No, you might have gone to LP school. LP school is up to 4th standard. So midbrain is LP school. So 3rd and 4th is there. Then UP means 5, 6, 7. So it is pons. High school and +2 means medulla, 8 to 12. Very easy. Okay. So the cranial nerves which are located on the medial part, one is 3rd definitely. Second is hypoglossal, 12th. Clear? It's
Also
very
they
easy.
said that again, they say that whichever is divisible by 12 is said to be in the medial aspect. So 3, 4, 6, and 12 are in the midline. Right? 3, 4, 6, and 12 are in the midline because they are divisible by 12. And other nuclei are lateral. This is easier for you to remember. So that has become more complicated. Okay, neurology is quite simple. Only thing is you need to get involved and understand things.
Anyone can guess why these are medial? Because no, the tongue is the most important thing. Then the eye is the most important. So these cranial nuclei require most nutrition. So they are, it's called, Saraswati concept. Means, they are Sarase Vasadi, means, they are close to the CSF. So very near to the periaqueductal cranium. Okay. So aqueductus sylvia, so the 3rd cranial nerve is just over the 6th, then the hypoglossal. Others are needed, but maybe the body has made in such a way, kept medially. So you are saying that the person is having a brainstem stroke. Now question, is it medial or lateral? So lateral brainstem strokes are characterized definitely one by ataxia. The second component to be needed is a spinothalamic tract. The third component to be needed is a sympathetic trunk. Sympathetic trunk. So trunk, spinothalamic tract, and this ataxia. Okay, with this you can add the cranial nerves. If you add what? The 5th, 6th, or 7th. Okay, 5th, no, definitely 7th, that goes for a lateral montine, either superior or inferior. If you add what? Palatal palsy to this, it goes for a lateral montine syndrome. It's a very easy concept. So if you are having a lateral, to say the triad of lateral montine syndrome, according to Paul Braces, the answer is
Spinothalamic tract.
no. It does not say spinothalamic tract.
Sir,
Okay.
cranial nerves are 9th, 10th level.
No,
Spinosympathetic.
see, the answer is here. Ataxia should be the second is the sympathetic trunk. Okay, then spinothalamic tract. Some article says, palatal. So palatal palsy is a must. So typical lateral motor syndrome definitely involves ataxia, contralateral spinothalamic. Okay, involvement, then horner, palate. So triad +1. So if you are having all these, you can say it is a classical
Lateral medulla.
Lateral. So your localization to the lateral part of medulla may be typical that we'll find out after examination. Now, is it over or what else you have to say? Is it thrombotic, embolic or hemorrhagic? Then you have to say what are the predisposing factors. That ends the history.
So it is thrombotic, sir, because there was progression of the symptoms.
What is called as a completed stroke in an ischemic stroke?
Why do you think that it's thrombotic?
So because there was progression of symptoms, sir, where in cardioembolic stroke, there will be maximum weakness at the.
What is called a stroke in evolution. So
Yes,
if there is a stroke in evolution, there is called as static hemiplegia. It tells you that it's a thrombotic. Right. It could most often place to the anterior circulation strokes, but still posterior circulation strokes also behave this way. They can have what is called as stroke in evolution. It is called as static hemiplegia. Right. Embolic.
Embolic will be maximum with the time of onset, sir, later, and there is faster recovery of the symptoms, sir.
Embolic is common, posterior circulation.
Yes, sir.
Sure.
So,
And why? Sorry, asking. Why? Which one is common?
Of the embolic stroke, most often it is
we will
cardioembolic
be-
or
it's
atrial. Yes.
Check, madam.
It's most often cardioembolic. Cardioembolic stroke, majority of the times, 70% of the time, that is right. Okay, and less it will be to the
See, you told me that the stroke is said to be complete in posterior circulation in 72 hours, whereas in anterior circulation it is 24 hours. Okay. Why not? Because the difference between the gray-white matter and brain stem. Okay. So the patient initially may develop unsteadiness. Only on the second or third day, even develop the complete manifestation. Okay.
So because there was progression of patient symptoms, I would like to consider thrombotic.
So a well detailed taken history is enough for making clinical diagnosis in neurology. So history should be taken, and your negative history should be a little bit. It should be in order actually, because the first symptomatology negative history should be from higher function, then cranial nerve, then you should a motor system, then sensory, then systemic symptomatologies. Okay. Now, let me ask one last question from history. What was the job that he was doing? Butchering.
Which is
So, what is so was he using his right hand, for butchering? You're doing something cutting.
left hand, sir.
Left hand. Okay. So with that, is it significant or not? Definitely, it's significant because if he's right or left, whatever hand he uses, if the subclavian is stealing blood from the vertebral artery, that's the most common cause for such an event to develop. So we should take what the person was doing prior to the onset of such a. Was he having the neck pain just prior to this?
No,
that
no.
indicates it's a vertebral dissection.
Yes.
Okay, so apart from the ischemic causes, you should even think of what do you mainly think?
what are the rarer causes which can occur, which can result in
So first
one
is,
is these are traumatic events. Then rarer causes
so,
as the likelihood claim and steal is one factor which can contribute to that.
so next is migraine also, sir. Migraine is one of the rare factors, sir. Next,
migraine.
then arterial dissection, sir.
Dissections can occur.
And then hypercoagulability, then vasculitis,
That's right.
then any recreational drug usage, so like cocaine and
More
amphetamine.
important than that is your neck massages. You should do barber chair. The neck massages can result, can damage the.
Patient with unknown Sherry malformation are prone for such.
So these are things which you should know. Unless you probe it, you will not feel it. Oh,
So
fine. Go ahead.
from the examination.
Okay, one more point I want to add. In the whenever dysarthria is there, sometimes we'll have problem to diagnose. So if there's associated neurological deficiencies are there, it is easy to diagnose. For example, cerebral symptoms are there, or there is 11 lesion is there. So you can easily attribute that was phase. So any drop attacks were there?
No,
Still
sir.
drop attacks.
No, sir.
What is subclavian steal syndrome?
Sir, when there is occlusion before in subclavian artery before the vertebral artery has branched out, when the patient is using that arm more, there is stealing of the blood from the vertebral artery of the opposite side, leading to symptoms of.
Who steals the blood?
So the vertebral artery steals the blood, sir, from the other vertebral because of the.
Who steals the blood?
Subclavian steals the
Ah,
blood, sir, from the other
steals the
side.
blood from
From the
vertebral artery.
yes, sir.
Because usually blood flows from subclavian to vertebral. But here what happens because of the exertion or heavy work on the hand, so the flow reversal from above downwards. That's why patient will have giddiness. Any condition you can say in a female patient coming with recurrent abortions,
Aplasm.
absent pulses, recurrent
The
stroke.
CVT.
No. Suppose a person comes.
One more clue I'll give. Upper limb
Pulse
limb BP is low, lower limb BP is high.
Coarctation.
No.
Tachyarthris.
So you have to examine. That's why you have to examine all the pulses. We have recently have seen one young lady coming with headache. We did CT, everything was normal. Patient discharged. Later, it was found that patient had absent left radial artery pulse. Usually we don't check. Later it was turned out to be tachyarthris.
We'll go for
very
prevention first.
General physical examination. Patient is conscious, oriented to time, place, and person. His recent, immediate, and remote memory is intact. Dysphonia is present. Comprehension, fluency, repetition. Sorry. Patient is conscious, oriented, time, place, and person. He is well built and moderately nourished. No pallor, itches, sinuses, clubbing, lymphadenopathy, or pedal edema. His pulse rate was
Is he having any hyperpigmentation?
Sir, there's hyperpigmentation present in the left lower limb, sir.
Upper limb as well.
Upper.
If there is hyperpigmentation in this scenario, what do we do?
Urocutaneous markers.
Neurofibromatosis.
No, vitamin B12.
Hyperpigmentation, sir. First,
See, vitamin B12 deficiency. Will it predispose the person for a stroke?
Yes, sir.
Yes, definitely. So, any other reason for his hyperpigmentation?
So, one is if the hyperpigmented patches are only present on the shin, I would like to rule out any diabetes, sir.
Since in hands and so, do you like to consider hypoadrenalism? Okay, which hypoadrenalism you will get hyperpigmentation? Is it additions of adrenal origin or is it pituitary origin?
Pituitary origin.
It's in the adrenal origin. Pituitary, you will get actually alabaster hypopigmentation. Whereas in adrenal, you will get MSH mediate. Okay, so your vitals?
So his pulse rate was 84 beats per minute, which is regular rhythm with normal volume and character. There was no radial delay, radiofemoral delay. All peripheral pulses were felt and no carotid bleeding was heard.
Okay, so what is the significance of pulse and examination in suspected lateral movements?
So I would want to rule out any cardiovascular stroke,
Okay,
postponed being AF.
we already anything else. Will you get any important of autonomic instability in lateral syndrome? Yes, you can get. So sometimes you may get reflex tachycardias, okay, autonomic dysfunction. So carefully look for pulse and respiration.
Respiration.
Any abnormalities you can get rarely. Have you heard of Ondine skirts? What is that Ondine skirts? Yes. The spontaneous ability to respire is lost. That's called Ondine skirts. So, okay, sometimes if it is a lateral buttock syndrome, it's a bleed, the person can go for central neurogenic hyperventilation. So, okay, be meticulous.
What about the reference and
What is the significance of the temperature? Suppose the person can have the hypothalamus is the center. So the sympathetic outflow from the is going down. The patient can have one half, the patient may have hypohidrosis or anhidrosis.
Right, what do you want to
Okay.
Then you have to make sure of cardiovascular.
Yes.
Something which you need to inform. Yes, please.
So first is patient has acanthosis nigricans, sir. There are no skin tag present, no xanthelisma is present. Arcus senilis, his age is he's 40 years old.
Then if it is a young stroke, the clinical examination is entirely different. So here, lack of time, we move on to the JVP is not considered as a vital.
in what phase?
High mental function examination. Patient is conscious, oriented to time, place, and person.
Screen
Please
time.
switch on the link, WhatsApp link.
You have to work on that. No?
Higher
His immediate recent and remote memory is intact.
Like
His
phone or-
speech is dysphonic. Comprehension, fluency, repetition,
Speech, no, you have definitely said what type of dysarthria he is having.
Dysphonia and dysarthria.
Dysphonia, sir.
But if you examine him, he clearly speaks. So what is the speech abnormality? You won't get actually a dysphonia. If you are getting a dysphonia, the larynx is definitely, so that indicates no lower middle way. Become laryngeal nerve and all. Okay, so dysphonia is usually, you won't get a dysphonia. Maybe a hypophonia. Or no, you have to definitely say the person is having this sort of a dysarthria. You have to examine and tell what type of element is dysarthria, or is it cerebral.
Internal.
But you will ask the patient to say to know whether it is cerebral.
Sir, I will text it to speech, sir. Basically, I want you to split the.
So what you will ask the patient to say?
What is mentioned in Hutchison?
It's articulary. You ask the patient to say articulary. If he says
Articulary, British Constitution, which are standard, which have been. You can use the Kannada words. Draupadi, Dhritarashtra.
His comprehension, fluency, repetition, writing and naming object was intact. Judgment and abstract thinking intact. Patient was emotionally stable. Concentration and calculation was intact. No apraxia, no hemi-neglect, and no.
Play the please mute audio and video on the mat.
Just
audio and mute.
yes.
why you are suspect? See, you already rolled out. Because you are saying neglect means why you are it's an anti-circular. So you need not do unnecessary things. That's what's
So when patient asked to draw blocks, sir, he tends to draw all the numbers.
That's what are the different types of evidence. Do you think it is a sensory attention? Is it visual? Is it
Sensory inattention. Sir.
Patient
Patient is not. Patient is unaware of his left side of the body. With the right side.
Sir, cut
ಎಲ್ಲರದು ಮ್ಯೂಟ್ ಆಗಿದೆ.
Cranial nerves. So visual acuity, visual field, color vision, and fundus examination all normal. Cranial nerve 3, 4, and 6. He had mild to
ಎಲ್ಲರದು ಮ್ಯೂಟ್ ಆಗಿದೆ ಸರ್.
right side. Extraocular movements were complete in all directions. His right pupil was 3 mm. His left pupil was 3 mm. Right pupil was 2 mm. Light reflex present. He had right gaze preference. Horizontal nystagmus was present. Fast component was present to the left side on right gaze and on right side on left gaze.
See, what your right gaze preference means? Basically, you mean a gaze palsy. Gaze preference is a function feature of which disease?
Actually, sir, it can again involve parietal lobe, sir, because of if it is a ischemic lesion, it will be towards the side of the lesion. If it's an irritative, it will be towards the opposite direction, sir.
So
Because of frontal
is it actually a gaze preference or is it's actually head tilt reaction? So the person is having ocular tilt. You are confusing that with the gaze preference.
It's the gaze palsy actually. It is that is a
Yeah.
Okay. What he is having is different. Yes.
The gaze palsy, if you say, that can happen either from the cortex or from the pons. Pons. There is PPR. So what is the difference of that? A PPR of gaze palsy versus a cortical. What is actually a PPR of? Yes. PPR has got 2 neurons. One is called a proper neuron, which will supply the ipsilateral attractus. And an interneuron. The interneuron will cross over to the opposite side. It will attach with the medial longitudinal fasciculus, will go up and reach the midbrain. That is the medial rectus nucleus, and it will supply. So any disease that is from the, suppose a person is having a right frontal lobe lesion. Okay. So the right frontal eye field will stimulate the person to look to the left side. So right-sided infarct, the patient will get a left-sided hemiplegia. So the patient will not be able to look to the left side. So he will not look to the hemiplegic side in a cortical. Whereas in a pontine lesion, the patient will look towards the side of hemiplegia. What is Vulpian sign? That is called prevost sign. That is a cortical lesion. If it is irritative in the cortex, now the patient. Okay.
Yes.
Ah.
Reversal.
So the patient now in a cortical lesion, you get a Wolffian sign. That is called prevost sign. Okay, so you are making unnecessary. So don't if you are not sure for a finding, don't bring such finding. So you say that the person is looking in a different angle. So actually he is having head tilt. Ocular tilt reaction is very common with lateral medullary. So you may get confused with the gaze preference.
So the seconds and pursuits.
Yes, sir.
There are any problems?
No, sir.
Yes. That's
What are the
when you look
ocular?
at the second, what happens in these scenarios? When you look into the ocular movements, specifically in
Yeah.
medullary.
Yes, 5 pages. What are the different ocular manifestations in lateral medullary syndrome?
Yes, others can contribute. What are the common manifestations?
Different types of nystagmus, different types of ocular reaction.
Like one is corner. First. Next.
Yes, saccadic intrusions. One, yes. Which one? Nystagmus horizontal as well as upbeat nystagmus described.
Then
Ocular tilt reaction.
So that is Q deviation
1 minute.
is present, sir.
Language,
The
language.
third eye being hypotropia to the normal eye, sir.
So the different ocular movements happen because of the vestibular nuclei, the otolith, okay, and the cerebellar involvement. So these three contribute to the different of the ocular abnormalities in it.
Let's present both sides.
Yes, sir. Present, sir.
There's 1.5 second.
So when the pons is also involved, sir, there's a pontomedullary infarct. That
Sir is asking you what is 1.5. The etiology, it's not the etiology, but what is it?
So it is the infarction, sir, which is involving
No,
the
no, what are the structures that are involved in medulla?
sir, one complete eye and the other eye patient is only able to have lateral gaze, sir,
Okay.
with
so the patient will have, I will have nystagmus.
yes.
Where should the lesion to have 1.5?
So it is in the pond, the basic part of the
which
pons,
portion?
the ventral part of the
Which
pons.
portion of
Ventral.
So sixth nerve and PPRF is
PPRF,
involved, yes, sir.
See, it is not sixth nerve, it is PPR
PPR.
ML.
So mainly medial aspect to the pons because MLF is there and PPRF is there.
It is looking towards the lesion and away from the lesion.
So when there is a ischemic lesion, there is looking towards the lesion. Whereas if it's an irritative lesion, the gaze is opposite to the direction of the lesion.
Initially, they are looking towards the lesion. Later, they can get the opposite. Whereas in brainstem syndrome, it will be opposite. Cortical, it is looking towards the same side.
Coming to fifth cranial nerve, patient's touch is intact, pain and temperature, sensation is absent over the right side of the face. His corneal conjunctival reflex is present, jaw jerk is absent.
So how is it possible to have a corneal and conjunctival present with pain and temperature absent over the right side?
So
Because that is not going hand in hand. What is the
What is
difference?
the afferent and deferent for corneal?
so fifth is a efferent, sir. Efferent is the seventh cranial nerve, sir.
Yeah, when you say the patient has loss of sensation.
See, is it corneal and conjunctival same afferents?
Yes, sir.
No, no. The corneal, it is pain and temperature. Whereas the conjunctival, it is a sensory. Okay, so if it is pain and temperature, is corneal. So definitely cornea will be absent because pain and temperature is lost. No? So you have to meticulously look for that corneal reflex. Okay, so the ataxia is on the right side, no?
Yes, sir. Right side.
Okay, so the patient is that means so you mean the whole entire half of the face is involved?
Yes, sir. All
That's
the three
absolutely
regions.
usually you won't get. Why you won't get that? What is the trigeminal pattern of distribution of the face called?
So first is ophthalmic, sir.
No,
Maxillary
that's a nerve. No, you are dealing with the spinal tract and nucleus with trigeminal nerve in the lateral. See, medulla, you are getting a trigeminal involvement. How is it possible?
This is spinal nucleus, sir.
Spinal tract and nucleus. So what are those fibers which are located in the medulla or the facial fibers? Which are those fibers?
Pain
You
and
think-
spine.
See, the tip of the nostril is represented cranially and the periphery is represented caudally. So that's called craniocaudal distribution of the trigeminal lemniscus. So you will not get the whole face usually. If you metically examine, you may get some part depending upon whether this spinal tract and nucleus of trigeminal nerve is okay. The somatotrophic representation of fibers in the medulla may be either anteriorly located, laterally located. So depending upon that, the different pattern of sensory loss. So you be careful in saying that no, its whole is involved because it is not like a nerve pattern. This is called onion skin appearance.
What is it called?
Even which portion of the face is not separate with trigeminal.
And has given some name.
On
Balaclava is a helmet. Okay. Onion skin appearance.
Onion
skin.
Sir is asking a very
Which portion of the face is
question.
not separate with.
So the angle of the jaw, sir.
Yeah. If the angle of the jaw is involved, if a person says no, the whole face is involved, angle is involved. So where it could be the lesion still. It can be, or see that usually rules out that it's not an organic. If the angle is also involved, it may not be organic. You want hemicranial sensory symptoms, semi-facial sensory symptoms with angle involvement usually may not be organic, but it can be organic. Scenarios, there is syrinx. Suppose the lesion is extending, syringobulbia, okay, so the C2 again will be involved. So we should be careful for that. Reference pulporesis.
Why jaw jerk is important here?
So jaw jerk is naturally absent, sir, to rule out UMN of LMN lesion, sir. If it is brisk, it includes UMN lesion. If it is absent, it is an LMN lesion, sir.
Where is the lesion?
The lesion is in the midbrain, medulla oblongata, sir.
No, jaw jerk.
Jaw jerk is present.
Jaw jerk, no, the nucleus.
No,
Where is
jaw
it
jerk is
located?
present.
It is in the
Oh,
pons.
Go ahead.
7th cranial nerve, nasolabial fold is present on both the sides, no deviation of mouth.
So suppose no, there is a element facial palsy. What is your diagnosis here?
Can it happen?
Yeah.
So because of geniculate fibers of
No. There's element facial palsy in a lateral medulla, your arterial localization.
so because of picas, posterior inferior cerebral artery is
It is ICA.
Usually, mica is the commonest. What you get the classical lateral medulla is pica. It's otherwise called as posterior cerebral artery.
If it is ICA syndrome, you can get a pondomedullary infarct. Okay, element facial palsy. Now UMN facial palsy.
because of the geniculate fibers, sir. Of
It is called the Jenner's loop or Digerent's loop. The genuflected fibers from the corticonuclear fibers will descend to the medulla or the lower part, and then it will go up. So you can get even. That is why even human facial palsy is considered as a false localizing sign in neurology. So you can even get that in medulla.
8th cranial nerve is normal, sir. Vestibulo-ocular reflex is present. 9th and 10th, the uvula is deviated to the left side at rest, and on movement of the uvula, gag reflex is intact. Taste sensation is intact on the posterior 1/3.
You check for the taste sensation.
Yes, sir.
It is very difficult and normal.
Sir, because
No, idiot, no. Testing sensation. How do you test taste sensation posterior anterior? You cannot do it by listen. You have to
Clinically,
it can be done by electrolysis, galvanic current. You cannot do it by clinical method. So don't put this. Right. Anterior to that only you can test. Right.
See, that means no, there is no palatal palsy.
no, yes, sir.
But
So, but initially he had, sir.
No, uvula is deviated, right?
Uvula is deviated at left, sir.
Uvula is deviated.
At
definitely.
left, sir.
That
But
is-
now,
He had some, but he is
now recovered. Now recovering, sir. Sternocleidomastoid and trapezius is normal. 12th cranial nerve, tongue is central with no
See,
fasciculation.
you are not supposed to say regarding fasciculation because no, it's an actual.
how did you examine the fasciculation?
So at the rest, sir.
Huh?
At
So you should not ask the patient to
to protrude
protrude.
the tongue.
So which are the cranial nerves where the deviation is to the same side?
12th and 12 and 5, sir.
Why?
So because they are pushing muscles, sir. They push towards the center.
Who will push? The normal muscles will push
Push
the
the-
towards the
opposite
center.
side. So that is in the 5th and
5th and 12th, sir.
so usually facial pulse, what happens it is the
It's the
opposite.
opposite side, sir.
Fine.
Motor system, bulk is normal in both upper limb and lower limb. Tone is normal, there's no hypotonia or hypertonia. Power is 5/5 in all muscle groups. +2 reflexes present in all deep tendon reflexes, and plantar is flexor bilaterally.
So tells you clearly
There's no
has no involvement of femoral reflex.
See, this is not the method for writing the reflex. You have to write superficial, deep tendon reflex, and release reflex.
I agree because you have simplified it.
Okay.
But at least
Yes, sir.
you are supposed to mention it completely.
How do you grade reflex?
So superficial reflexes.
No. So there is no grading for superficial. Deep tendon reflex, how do you grade?
So there are 5 grades, sir. First is grade 0, which is absent. Grade 1, which
Grade
is
0 is
diminished.
absent means what? Just absent? Absent even with Gendrasix smell. Okay, then
Grade 1, sir, in
it
which
is
there is
called +1.
+1, sir.
+1?
Diminished, sir.
No. So how do you know it is,
Hyporeflexia.
how do you know it is diminished? It's called elicitable as that of the
Just
angle gel. Elicitable as that of angle gel. +2 is called,
+2 is normal, sir.
what does that mean? Elicitable as that of knee jerk. That is called as brisk. +3 is called
Hyperreflexia.
exaggerate.
Exaggerate.
And +4 is called
Clonus is present, sir.
This is how you grade. So if you say +2 means no, your angle jerk is exaggerated actually. So angle jerk should be +1. So you are saying that is +2. That means we anticipate the person to have a hyperreflexia in the angle. See? Now you understood. Now,
Yes.
if you make comments like this, angle jerk +2 means it is not a normal.
Hyper.
Yeah.
Yes.
Clonus indicates what?
Clonus indicates human regions, sir.
No.
Hyperreflexia.
Clonus tells you that patient has hyperreflex. Right. Clonus just tells you that patient has hyperreflex.
Indicates what? It's got an extensive lesion. Got it.
See, suppose the plantar on the right side is extensor. What is your diagnosis? What is submedullary syndrome of Opalski?
Or in other words, where can there be pyramidal involvement in bilateral medullary?
Suppose there is
No, can
No,
there
so-
be any others? Can there be pyramidal involvement in bilateral medullary? 100 to 99% is no. 1% yes. It's the rare syndrome called Opalski syndrome. Very patient not because submedullary fiber being affected.
So if you are getting a medial with a lateral medulla, you will get extensor plantar on the opposite side. On the left, you will get extensor plantar. That is called medial with a lateral medullary syndrome. Otherwise called Babinski-Nagotti syndrome. Okay. Suppose you are getting ipsilateral plantar extensor. That is
Can you get that? Ipsilateral plantar extensor. Yes, so how can you get ipsilateral plantar? You get the opposite side pyramidal involvement there.
Yes,
How
sir.
do you can you get ipsilateral plantar?
If it has already decussated, sir.
yeah, fine.
No, there is if the lesion is slightly below the medulla. What happens? The pyramidal fibers just decussate below the medulla, right? So if there is decussate, they're just below the medulla, and it's extending below to the just below the medulla, then can be not the it can have ipsilateral plantar.
See, if similarly, sir was saying this, no, similarly, you will get a hemiplegia cruciata. That means, no, one side upper limb and the opposite side leg involvement. So these are common with what? Medial medullary involvement. Sometimes you may get a pure what? Hemiplegia, sparing the face in the medial medullary lesion. Okay, so these are the different variants. So you should be aware. Suppose you are getting an extensor plantar. These are the thought process.
First case variant is
Okay,
really
variant. So you have to think, is the patient having multiple infarcts? Sometimes the patient might have had an already stroke. So that might be the reason for an extensor plantar. Need not be the current. So for that, now you check any release reflexes present. Suppose it is there, it may be an old cortical infarct which might have produced the extensor plantar. So you can either associate or dissociate based on the scenario.
Sensory examination, his fine touch was
See,
intact.
one tone you didn't mention, tone. Is it hypotonic?
No, sir. Normal tone.
Actually, when you are going to say regarding the cerebellum, the tone should be what? Hypotonia. Okay, what is the order with which recovery happens in hemiplegia? In a usual hemiplegia, what comes first? In a hemiplegia, suppose the patient recovers, is it the reflex, is it the tone, or is it the power?
Tone, sir.
It is reflex first.
What
It
you
is
say
called
is
RTP. It is reflex first. Which reflex? If it is dependent reflex, it is angle. So reflex, tone, power. Suppose in a stroke, if you are getting power is grossly appearing normal, but the tone is lagging behind, you are suspecting attacks hemiparesis. Okay, suppose a person who is saying that he is weak. Okay, now after you examine, you feel the power is normal, but still weak. There may be cerebellum may be the common organ. So there's a need for knowing a reflex tone power.
Well,
Sensory examination. His pain and temperature was reduced over the right side of the upper limb and lower, no, right side upper limb, left side upper limb and lower limb sensation was reduced. Other sensations
So
like
vibration,
vibration,
joint position, are
everything
intact.
intact, sir.
So what does that indicate?
Spinothalamic tract involvement, sir.
Joint position and vibration intact means what does that indicate? So that means
Posterior
that
column is present.
posterior column is normal. That means the posterior column deposits at the medulla and it is becoming a medial meniscus. So the lesion is little bit
above.
above.
Cerebellar signs. His finger nose test was done. Dysmetria was present on the right side. There was no dysdiadokinesia. Ataxic gait with swaying towards the right side. Intentional tremors present on the right side. Rebound phenomenon present on the right side. Patient was swaying towards the right side while walking. There were no signs of meningeal or
you can put it later. What is important? Patient has
cerebellar signs on the right side.
signs,
Yes, sir.
predominantly
Right side, sir. Other systemic examination were normal.
So here what specifically you should look for? The vertebral bruit. Okay, you look for a vertebral bruit. Okay, because we are dealing with that. No? Then cardiovascular system specifically for atrial fibrillation, any cardiovascular disorders, both upper limb BPs. Okay.
With this, my final diagnosis is ptosis, neurological deficit present at
So
ptosis.
you need not write like this.
Okay.
what are the first one? 2 lines got
So it is indicating Horner syndrome, sir, on the right side. Sir.
What component you have left off in Horner's?
Sir, ciliospinal reflex, sir.
You have put that.
Loss of ciliospinal reflex on the right side, sir.
What is not there? Ptosis, meiosis,
And anhydrosis, sir.
anhydrosis, ciliospinal reflex,
Yes, sir.
and
Well,
5 components. Right.
So is it a first order Horner, second order, or a third order?
What do you mean?
How do you distinguish between these three? What is a, can you trace the sympathetic pathway? Starts from the hypothalamus, then it goes down. Anyone, any student? So it goes down, reaches the medulla, then it goes down, it will reach the intermediolateral column of ciliospinal center of Budge, the C8 and T1. From there it goes along the C8 T1, goes to the inferior, middle, and superior cervical ganglion. So even though it goes to the inferior and middle, it will synapse with the superior. From there, the next order neurons comes, and it goes along with the carotids. Okay, then those destined for the face will go along with the external carotid, and those destined for the ocular will go along with the internal carotid artery, and it will go up and it will reach the cavernous sinus, and then it will go and supply the Muller's muscle and does this function. Okay, so this is the 3 levels of Horner. So is your Horner at the medulla or is it at different levels? No, so the pattern of presentation will be different.
For example, patient has a superior cervix tumor. Okay,
Pancreas.
Patient has cerebral sympathetic involvement. There, the system is totally different from what you see here in middle. Right.
So you have to write your diagnosis like cerebrovascular disease, posterior circulatory stroke,
yes, sir.
lateral medullary syndrome, right? Okay. Then, so which arterial territory you mean?
So,
How do you classify the arterial territory of the posterior circulation?
So because one is internal cavity, which is anterior circulation. Sir.
No,
Posterior circulation, vertebral artery, basilar artery dividing into.
No, what is the arterial system? It is divided in vertebro-basilar system. There are 3 sets of arteries. Which are those?
So first is posterior inferior cerebellar artery, and
The three sets of arteries. One is called paramedian. This is very easy to remember. Paramedian, which will supply the medial aspect of the brainstem. Then second is called the short circumferential, which will supply the lateral part of the brainstem. You have got three long circumferentials, which are called pica, ica, sca. So pica is the artery of inferior cerebellar peduncle, which will supply the lateral part of the medulla and the cerebellar hemisphere. Okay, ica again is arising from the pondomedullary region, and it will go and supply the lateral part of medulla, will go and supply the cerebellar hemisphere. Again, the scar, which is a superior division, and it will supply the lateral part of the midbrain as well as the superior cerebellar surface. So this is very easy to understand. So are we dealing with a vertebral artery? Is it a pica, or is it the other arteries which supply the medullary, anterior and posterior spinal arteries? Okay. So among this, you can presume that it can be a.
So lateral medullary could be the
Vertebral.
any of the five options. So most likely it's vertebral.
then it's posterior.
It's posterior.
Yes.
So you have made a diagnosis. So how you are going to investigate him?
So first we'll do routine investigation, sir.
Suppose he has come to the cash.
Yes.
So this is the hemogram. Okay, can you enlarge?
So his total HV was 17.9, sir. PCV of 51.8, sir. Polycythemia, sir.
Can you liberate polycythemia?
So because HV is more than 16.5, sir, in male, and PCV is more than 49, sir. Yes, sir.
So you are considering it as a primary polycythemia, or is it a secondary polycythemia?
It's a secondary, sir, because there is.
Before we discuss this now, we will just
If you can come something. Want to see that? बंदे जल्दी आए ना कमिंग
and pursue its following the following objective. See, first of all, you look for the object. You start from each of the areas. The 6 cardinal divisions.
ಅಂದ್ರೆ ಇದಾದ್ಮೇಲೆ ಇನ್ನೊಂದು ಪ್ರೆಸೆಂಟೇಶನ್ ಎಲ್ಲ ರೆಡಿ ಆಗಿ ತಲೆಗೆಲ್ಲ ಕೈ ಇರ್ತವೆ
ಕೊಡು
The area post.
ಹಾಗೆ ಅವರು ಕ್ಯಾಮ್ರಾ
We got that.
ಯಾರಿಲ್ಲ ಅಲ್ಲಿ
That's deviation. And we can record that's one. Right. Is smaller compared to the left side. Okay. There is next dilatation of the pupil. Okay. So usually what happens with hard happens there will be loss of serious condition. Right. Yeah. Bring the object from right. Okay. Then ask him to close the size. Can we check? Can we close? Can we check? And we report this. This ocular movement it's again component which is upon and lateral portion which is often typically seen with lateral portion. Lateral portion. Otherwise could be ipsiplon. Ipsipus. What is Fournier testing? Huh? Yes, you are testing. It is the resistance. What do you mean by tone? Tone refers to the resistance offered by the resting muscle, passive movement. So you definitely need to check the resistance offered by the resting muscle. Okay. Can listen the difference. Volume. Because of injury, right? This you need to map out. You cannot just write a generalized all of us.
അവളോളം നയിക്കുവാനായിട്ടാണ് അവരത്
What is described as a sign analysis technique? Huh? What is practiced is just strike the lateral border of the sole. Okay, and yeah. What you need to do is just strike the lateral border of the sole. Okay, between the junction between the thick skin and the thin skin. Okay, one, and never cross the bar of the toe. Muted. Noise. And never cross the bar of the toe. Why? You may pass this to me. May ask you this. Unless you do it for proper technique. This is how you do. This is how you do. That's how you do. No. First thing is you cannot do that way. And you're taking the picture. Fix it.
Do rapid movements once you fix them. Then ask the patient whether the toe is involved or not.
And give you a final diagnosis and go to prognosis. But just out the investigation, right?
We were discussing the polycythemia part. No?
Yes.
So you were saying the patient was having polycythemia. So from the hemogram itself, can you say it is a primary polycythemia or a secondary polycythemia? From the hemogram, what are the classical features of a primary polycythemia in hemogram itself? What is called microcytic erythrocytosis? So you told hemoglobin is 18. So from that, now if the MCV is very low, if there is pan myelinosis, means all lineage is increased. That indicates it's a myeloproliferative neoplasm. So microcytic erythrocytosis, okay, with a high hemoglobin and myelinosis are more in favor of a polycythemia rubra 1. Okay. Otherwise, no, here no, it's not. It's MCV. Look at the MCV, which is 95. You know, so it's so microcytic erythrocytosis seen in 3 conditions. Which are those? One is polycythemia. Second, sickle cell trait. Third, hypoxia. So here it's PC. Your MCV is 95. So it is not in par with a primary. Okay. So so it may be maybe a smoker, or it may be hypoxia induced by COPD emphysema. Suppose a cerebellar lesion like this and a polycythemia. Any other rare thought process you have got?
Any malignancy, sir?
What malignancy? Any opinion? So cerebellar hemangioblastoma is associated with polycythemia. So one of the malignant causes for polycythemia is hepatoma, uterine leiomyosarcoma, then it is cerebellar hemangioblastoma. Then polycythemia with stroke again can happen with ADPKD. Okay, so these are the concepts you should think when you say hemoglobin of 18 in a person with a stroke.
Highest DSR and stroke. Can you tell something?
Any vasculitis, sir?
Infections,
Vasculitis, malignancy,
tuberculosis, abdominal disease, retroviral infection.
So your potassium is normal,
Yes.
sodium is normal, just RBS.
Random blood sugar is 125, sir.
Okay, fine. So electrolytes are normal. RFT.
So RFT is also normal. So urea creatinine is normal.
Okay, so you have written TSH is low. Why so? How do you interpret that?
it's 0.36, right?
Yes, sir.
What is your explanation for that? You call this a sick euthyroid state. Patient clinically does not have any symptoms. Okay, so if so, that means this one of the is T3 T4 normal.
Normal, sir.
Okay. Okay. So X-ray ECG directly on the ECG. So ECG you have to look for whether there is any AF. Okay.
Normal sinusitis, sir.
It's a normal. Is there any LVH?
No,
Because now suppose a person is having a hypertension of BP of 210/110. You are seeing the patient on this day of the stroke. How do you know it is a pre-existing hypertension or is it a reactive one?
by looking at ECG, sir, if there are any.
But looking at clinical.
What are the things we usually look for? One, look at pulse.
Yes.
Usually it will be bounding or then look at the
Auscultation,
fundus.
Fundus.
Okay, which may show evidence of arterial changes. 3, ECG, which may show evidence of LVH.
You may look for a heaving apex, a fourth heart sound, an
Loud,
ejection
yes.
systolic murmur, okay, and end organ damage from hypertension. Okay.
This is patient's MRI, sir.
Okay. Is there any picture?
No, just put the report.
Okay.
Acute lacunar infarct in the right parietal lobe. Absent flow related signal intensity in the right vertebral artery, query thrombosis. Mild prominence of right vertebral artery with vascular compression of the right hemimedulla. Vertebral artery compression of the medulla syndrome.
What is the blood supply of parietal lobe?
Parietal lobe, middle cerebral artery, sir.
Okay. So why he is having a right parietal lobe? So this might be the reason why she has brought the gaze preference. Okay. After seeing this MRI. So what is the so what do you consider now? Now your patient is having a stroke in the anterior circulation as well as another stroke in the posterior circulation. So where you should search for?
Cardioembolic can be one.
Definitely you have to consider an aorta or its branches. Okay. So it may be an artery to artery embolism. That is why one infarct is there in the right parietal and the other, because you are not getting any features of a parietal lobe infarct per se in this patient. That too, it is in the right parietal lobe. Okay. So,
What is the this one you get in the parietal lobe lesions, right? As a to right parietal lobe.
So if it is dominant hemisphere, which is
Here.
right parietal lobe is
Okay.
dominant hemisphere.
And yeah.
If it is his dominant lobe, so then there will be aphasia, sir.
Aphasia?
Wernicke's aphasia, Broca's aphasia.
parietal lobe.
Parietal lobe, dominant lobe, if it's involved, sir. if the dominant lobe is involved.
See,
If patient's
where is the
dominant-
Broca's area located?
Broca's away left parietal lobe, sir.
Parietal lobe. That is in
Broca's.
the-
Sorry, sir.
See, Broca's is in the frontal lobe.
Frontal lobe, right? Inferior frontal.
Okay. So you won't get an aphasia.
Wernicke's aphasia, sir.
Wernicke is located where? Where is Wernicke's? Is it in
In
the
the superior
parietal?
part of the temporal lobe.
Ah,
sir.
it-
But
Temporal
uh,
lobe.
So why you are concerned with speech
sorry,
and
when we
parietal?
MC a territory, it will be not. In parietal lobe, patient will have Gestaman syndrome, sir. The dominant lobe is involved.
Those are very, we won't get such syndromes. Okay. So regarding that syndrome, since you mentioned, see the syndromes of the vascular syndromes of brain, like biliary lobe, like any brainstem syndromes, it is very difficult to get. Why? Because the medial part of the brainstem is supplied by one peculiar artery and the lateral part is supplied by another. So thrombosis, these two arteries are required to produce the clinically named syndromes. Okay, so all those were diagnosed and detected and named after the postmortem studies that I have done in the years back. Okay, that's why the syndromes and all usually we may get, but need not always in ischemic stroke syndromes. The point is ischemic stroke syndromes. So Gersman and all you can get, Mandan syndrome you can get. Okay.
And in
See, I was telling regarding the brainstems, named syndromes. But in cortical, you may get all syndromes.
And in non-dominant lobes, a patient will have agnosia.
Yeah.
And
What is the definition of apraxia?
sir, inability to perform learned activities in the absence of any motor sensory involvement. Sir.
Complex coordinated motor activity.
Yes, that is a very important thing. No? Learned skilled motor activities. Okay. So you are saying the person was having a right vertebral artery infarct. Okay.
So it could be one of the vertical, it could be one of the causes for lateral syndrome. Right, fine.
So that is a feature of left non-dominant lobe, sir. There's both dressing and construction apraxia. And this is patient's echo. It's,
So
normal,
almost
sir.
now,
Normal, sir.
ejection fraction is also good, right?
This is his normal, sir. We got CT angiogram done. That is showing reduced contrast opacification and calcification along the V4 segment of the right vertebral artery with near total luminal narrowing, likely atherosclerotic etiology.
So how many segments are there in the vertebral artery?
4 segments.
So V1 to V4.
V4, sir.
So if the person was attending your casualty, would you might have thrombolized him? Yes or no? Yes or no?
Yes.
So according to what criteria? What is the difference between the thrombolysis in anterior and posterior circulation? How do you thrombolize the patient?
So we give altiplase, sir, which is 0.9 mg per kg, maximum dose being 90 mg. 10% to be given over 1 minute and the rest dose to be given over 1 hour, sir.
Fine. So what is the difference between anti-circulation stroke and post-circulation?
In thrombolysis.
Is there no difference or is there?
Any other different scoring systems? Yes.
That is in CT,
this-
sir. Aspects, so we do it in CT, sir, to rule out any
Yeah.
lead.
Aspects for the anterior circulation. Okay. So if you do a posterior circulation, the problem is you may not get the 4.5 hours. It may be sometimes difficult. We may not get the complete picture. So we may think it may be a minor sensory stroke. So we may not thrombolize. So there is a problem with the posterior circulation. We may not get the complete picture of the posterior circulation. We may not get the MRI at that time. So if we are getting that, then well and good, we can go for a thrombus. But in anterior circulation, it's very easy to decide. We may not be having any trouble, but in posterior, it's usually difficult. So in posterior circulation, do you want to perform any thrombectomy or anything?
It can be performed within 24 hours, sir.
Okay. What is the guidelines for management of hypertension and diabetes in acute ischemic stroke?
So if patient's blood pressure is more than 180/100, sir, we would want to bring it down so that we can perform
So what all
thrombectomy.
drugs you can give?
So IV, we can give labetalol, nifedipine,
Nifedipine
sorry,
you give?
No.
not nifedipine, sir. Nicard, Nicard,
You have got nitroprusside, you have got nitroglycerin, you have got labetalol. Which is ideal?
and labetalol, sir.
Okay, why not nitroprusside?
So it causes reflex
No,
hypotension.
no, that will produce increased intracranial tension. So nitroprusside should not be given for that, whereas that can be given for a hypertensive LV dysfunction. Okay, so what is the target BP nowadays?
So
You need not reduce the blood
by only
pressure.
5%, sir.
No. So a drastic reduction of blood pressure should not be done.
Why?
So it can lead to penumbra. Because of penumbra, we need adequate blood
It will
supply.
affect the cerebral autoregulation.
Okay, so what is that? See, when a person comes with a, okay, so that I think the time is over.
Nice presentation.
Yeah, you have presented well. So the thing is, when you present now, you need not you have to elaborate the symptoms. Then based on the symptom, always know since this patient in nutshell, no. So this patient had an unsteady gait, difficulty in swallowing, with a drooping of eyelid. So if you think for a anterior and posterior, it's very easy that it's a posterior. The next no, whether which type of an element cranial palsy is there. Is it a fondine? Is it a midbrain? Is it a medullary? So here it's very easy that it's medulla. So you know that the palate is located on the, that means the nucleus ambiguous is located on the lateral side. So it is a lateral part of medulla. To get a company, you can take what the cerebellum, that is inferior cerebellar predominant. So the diagnosis straight away goes for a lateral medulla. Then see, there may be, it's called as a tea. We may put sugar in it. We may put some masala. Like that, lateral medulla will have the classical features of the triad. With that, now you can have any other components. So to say it is lateral medulla, ataxia is a must, palatal palsy is a must, contralateral hypotension is a must with horn. Okay, so keep that in mind. So that is lateral medullary syndrome. Do examination and don't say regarding reflex and all by simply writing 2+1+. You just examine, see patients regularly, look for clinical findings, make out a proper clinical diagnosis and write down case sheets. That will help you for perform. Best of luck. On the best.
Any question from other PGs?
Thank you, Dr. Karya.
No questions. More
Mr. Chairpersons. I request Dr. Basuraju, Professor of Department of Medicine, AIMS Bangalore, to hand over a token of gratitude to the chairpersons.
Live close ಬಿಡೋದಾ live close ಅಲ್ಲ right so ಇದು live close ಮಾಡೋದಾ live close ಮಾಡೋದಾ light on ಮಾಡಿ ಸರಿ ಇದು live close ಮಾಡೋದು live
30 minutes for presenters will be awarded at the end of discussions. Our next clinical case discussion will be on RS by Dr. Sharanu Prasad Kolar, third year postgraduate, Department of General Medicine, MMCRI. I request the chairpersons, Dr. Jairaj BS, Professor of Pulmonology, Jesus Medical College, Dr. Srinath KM, Professor of Medicine, Jesus Medical College, Dr. Smitha Bhatt, HOD of Medicine, Father Muller Medical College, to chair the session.
A very good evening to everyone. I'm Dr. Sharan Prasad, the final year postgraduate from Department of General Medicine, Mysore Medical College. With the permission of chairpersons, I'd like to present a clinical case on respiratory system. So here is a patient named Mr. M, who is a male patient, aged 69 years, hailing from Hassan, studied till 3rd standard, who is a coolie by occupation, has stopped working since past 6 years, informed being himself, and was examined today. Patient presented with the complaints of cough with expectoration since 10 years and breathlessness since 4 years. Patient was in his usual state of health until 10 years ago when he developed cough with expectoration, which was insidious in onset. Cough occurred in bouts, usually lasting for a few minutes, with few bouts lasting for up to an hour. Cough exacerbated during the early morning in rainy and winter season and after dust exposure, and it relieved temporarily upon taking medications. There was no postural variation. Cough was gradually progressing in the form of increasing number of frequencies of cough episodes per day. Sputum was around 15 ml in quantity. It was whitish in color, mucoid in consistency. However, during the periods of exacerbation, the color changed to greenish or yellowish, with consistency changing to mucopurulent, with increased amount of quantity of around 40 to 50 ml during the period of exacerbation. The sputum was non-foul smelling and occasionally blood tinged. It was a bright red in color. Patient also complains of breathlessness associated with wheeze since 4 years. It was insidious in onset, gradually progressive. Patient initially used to feel breathless only upon strenuous work. That was MMRC of grade 0 until 4 years ago, when he started to feel breathless even upon walking for around a kilometer. That is a distance between his home and his workplace. So this prompted him to stop going for work. Since 1 year, patient started feeling breathless and has to take rest even upon walking half a kilometer or climbing of 1 to 2 flights of stairs. And during the period of exacerbations, breathlessness was worsened to an extent that patient could not even walk even a few meters and had to take rest. Breathlessness worsened during early morning in just like expectoration. Breathlessness worsened in early morning and in rainy and winter season and after dust exposure. It relieved temporarily upon taking medications, and there was no postural variation with the breathlessness. Although the patient prefers to sleep on the right side with no obvious reasons, but he does not per se complain with the postural variation. There's no history suggestive of orthopnea or PND. Since past 4 years, patient used to have episodes of worsening breathlessness along with cough exacerbation and sometimes fever, severe enough to undergo hospitalization. He was hospitalized around 5 to 6 times in the past 10 years. Frequency of exacerbation increased in the past 10 years, with him being hospitalized thrice in the past 1 year, with the last hospitalization being almost a month ago, with worsening of the symptoms. And there's also a history of weight loss since the past 1 year. He has lost around 4 kgs from 59 to 55 kgs. This was not associated with loss of appetite. There's no history of fever in the recent past. There's no history of chest pain, no history of palpitation, no history suggestive of syncope, no history of lower limb swelling or abdominal distension, no history of retching or regurgitation of food, and there's no history of recurrent nasal discharge or post-insulatory. Coming to past history, around 50 years ago, when patient presented with fever, easy fatiguity and breathlessness to a private clinic, he was diagnosed to have a pulmonary tuberculosis and was initiated on anti-tubercular therapy. He took the tablets for 18 months, and later again a sputum test was done and it was told to be negative. For the past 40 years, patient used to have episodes of cough with exacerbation, especially during the rainy season, for which he used to go to the hospital and take medications on the OPD basis. However, he was completely asymptomatic in between. He used to have exacerbations once in 2 or 3 years, but he was asymptomatic during the rest. Patient was completely asymptomatic and he was operated for right upper limb fracture due to a trauma around 50 years ago. Family history, there's no history of tuberculosis in the family members. Diet is mixed, appetite is good, sleep is undisturbed except during exacerbations when he used to have a disturbed sleep. Bowel and bladder is normal and patient is not allergic to any food or substance. Personal habits, patient smoked around 40 BTs per day for 30 years. However, he stopped smoking around 20 years ago. Smoking index comes to around 1,200 and pack years of 15. Drinks 300 ml of beer every day and units come to around 8.4 units per week. Activities of daily living, patient is able to carry out most of his activities of daily living without any support of any attender.
one question. Now you mentioned this lying down with to the right.
Yes, ma'am.
Why do you think that is?
That might be a subtle indicator of him, the position of the disease being on the location of the disease being on the right side, ma'am. But he per se does not mention that his symptoms exacerbate on lying on left.
When
He
was
prefers
admitted-
to-
Okay, I understood. When he was admitted to hospital,
Yes, ma'am.
do those exacerbations coincide with increased purulence or sputum?
Yes, ma'am. At times purulence, at times fever, at time most of the times with increased breathlessness, ma'am.
Just goes through the history. So what is your historical analysis? Because there is an elaborate history that we could see. So what is your history analysis based on that history? Let's consider, so he is almost 50 years back, he suffered from tuberculosis. He took treatment for 18 months, completed treatment. Then after how many years after that he has developed all the symptoms?
Almost 40 years he was asymptomatic, sir.
Absolutely asymptomatic. So only
Except for the exacerbations,
the
sir.
last 10 years he has been symptomatic.
Every day.
Okay, what do you think that cough? How do you analyze that?
With a significant history of tuberculosis and a symptom-free interval of around 40 years, this could be a case of probably a sequel of tuberculosis. But him also being a smoker, it could also be a chronic obstructive pulmonary disease. And the occupation which he does, there is a fair bit of amount of exposure to dust. He carries rice baggages and the wheat baggages, so could also be an occupational lung disease. And considering his age, could be a malignancy too.
Right. Many etiologies may be operating in this patient.
Yes.
But post-tubercular patient, number one. Number two, he has a chronic smoker. Definitely that gets into it. And his work probably is occupation also. Based on that issue, what do you consider? 1, 2, 3. How do you analyze the cough? Because it's a chronic cough anyway. It's a chronic cough with significant expectoration. So historically, how do you analyze it? Is it pleural disease contributing, or airway disease contributing, or the parenchyma, or the combination of airway as well as parenchyma?
His breathlessness was associated with visa, and there is expectoration too. So this could be a combination of both airway as well as parenchyma involvement.
Does it history classically fits into your historical diagnosis of chronic bronchitis?
Since past 10 years, yes.
Tell us the definition of chronic bronchitis, because it's a history diagnosis only. Chronic bronchitis is an history diagnosis only.
Cough with sputum production for at least 3 months for at least 2 consecutive years.
A cough with significant sputum production for more than
3 months.
Okay.
For 2 consecutive years.
2 consecutive years. Is it there? This patient? Probably.
Yes.
Okay. Okay. Then what are the other 2 important history in the symptom that would suggest that he has got airway disease, predominant airway disease?
One is the B, sir.
Yes, B definitely goes in favor of airway disease. Then
expectoration.
Cough with expectoration. So in between, is the expectoration used to change? Is cough frequency used to change? What could be the reason?
It was usually a seasonal exacerbation, sir. Could be any viral pneumonia exacerbating the pre-existing conditions.
Probably either infection or any other triggering factor would have altered his cough morphology as well as sputum morphology. Right. Okay.
What do you think the breathlessness is due to? Apart from the obstructive airway disease, is there anything else which might be causing the breathlessness in him?
Parenchymal destruction would also be a cause.
It would have to be quite significant. You would have to be thinking of bilateral, fairly significant if that's what you're thinking. Could it be anything else? Look at the broader patient who's had a long time. Could anything else be causing exertional breathlessness? Pardon?
Underlying cardiac disease.
But anything simpler than that?
What do you see commonly more than pulmonary hypertension? How common is the pulmonary hypertension? Suppose if this man to develop pulmonary hypertension, how significant should have been the respiratory disease? He must have developed complication of a primary disease. Okay, he should have developed carpulmonary, right?
Not a man from a lower socioeconomic status, I'm guessing.
Anemia.
Fair enough, isn't it? Anemia. So we should not miss such simple things. The
Right.
exertional breathlessness.
Anemia would have contributed, infection must have contributed, and even exposure to dust, fumes, some other new toxic chemicals would have contributed to the exacerbations. Right. Should always think of those things.
Do you elaborate occupation little?
He was basically a coolie by occupation.
Coolie means,
Sorry, sir.
coolie means what?
He used to
exactly
carry the
is
baggages from the go down to the vehicles,
What
lorries.
material is exposed to chemicals?
It was
cement,
mostly
cement,
rice baggages, sir.
Cement bags, rice bag, something like that.
Rice and wheat, sir. No cement bags.
No cement.
No
Better
cement.
not to use that word coolie. All of us are coolies only.
That's
Because
that
there is a manual laborer. Okay.
Exposed to dirt, smoke, something at the place of occupation.
He gives a significant amount of dust exposure previously.
Little when he had tuberculosis.
Yes.
What treatment he has taken? What was the status? Anything? Any idea? If you can get little bit probe into that past history.
That time,
What kind of tuberculosis he had? Is it pulmonary tuberculosis, extrapulmonary tuberculosis, whether it's effusion, whether it's a parenchymal, something clues like whether it's hemoptysis, something when he had half expectation, whether it was producing sputum, had hemoptysis, something like that. At least clinically, radiologically, some clues he had.
during the period of
Some clue as to the parenchymal involvement, something like.
at the presentation of when he was diagnosed as tuberculosis,
That's a recall bias always. But if you could remember that.
he only said that he had easy fatigability and fever, sir, when he presented to hospital.
The place where he was treated, like in sanatorium or peripheral.
In the private clinic in Mysore, sir. He was diagnosed, sir. Then he was referred to PKTP, sir.
Somebody would have told him that there was some problem in the X-ray or something like that. How many tablets he has taken, how long he has taken, was he hospitalized, kept in the hospital for a few months, given treatment, some injections. That will give us a clue as to the significance of his illness at that time. That give us the extent of damage to the lung, something like that. And subsequently, after that, what happened? Was he asymptomatic totally? And has been having symptoms since then.
He had periods of exacerbation in between, sir.
In between.
Yes, sir. Almost once in 2 years.
Symptomatic from the time he developed tuberculosis.
He was asymptomatic for 10 years, sir. Then since past 40 years, he was symptomatic, sir. But only during exacerbation, only in seasonal exacerbations. Other time he was completely fine. He was going to work.
So after that, he has been having recurrent cough expected seasonally.
Seasonally, sir.
He has given a history of chest pain, isn't it?
Only
Can I
after
ask- yeah.
continuously coughing, he
Can
gives a
one
history of
minute.
chest pain.
Can you tell me the involvement of tuberculosis involving the lungs? Pleura,
Bronchial,
parenchyma, airway.
yes.
Okay. You have heard of post-TB bronchitis? COPD? Etiology, how it happens, how it presents, difference between TOPD and COPD. If both are there, he is exposed to smoking. Natural course, progression. Any idea if you have?
Tuberculosis, TOPD usually occurs 2 to 5 years after the episode of tuberculosis.
2 to 5 years, it may even after 10 years also. It depends. Depends upon the external factors. It may present like a COPD. It depends upon the extent of involvement. Whether he had endobronchial tuberculosis, parenchymal tuberculosis, or if he had severe bronchiolitis, then tubercular bronchiolitis. Depending upon the extent of involvement, site of involvement, the subsequent presentation differs. Okay. If you had already had endobronchial severe bronchiolitis picture, development of TOPD is early and it's rapidly progressive. Okay. So that gives us a clue. If we had earlier knowledge of the extent of tuberculosis which he had. Okay, that's the reason we want to know what is the extent of TB which he had initially. Okay. So that could be the additional factors. Along with that, smoking is to know what exactly underlying problems which he has. But, okay.
So in a patient like this complaining with chest pain, at this point, he did complain of occasional right-sided chest pain. Analyze that history. Let's think, for the sake of argument, it's pleuritic. What might be the causes of pleuritic chest pain in a man with this particular history that you gave?
One could be pleural thickening or calcification causing.
Does calcification cause pain?
He told that he used to get chest pain only after coughing for a
What
several.
are the possibilities you are asking? Suppose if he develops a chest pain in this background, so what are the possibilities that you would like to think?
Could be a secondary malignancy causing eroding the ribs, causing the chest pain.
Okay. So suppose if he's repeatedly coughing, suddenly develops chest pain, what do you think? Severe bouts of cough, then
Pulmonary infarction.
After coughing, severe bouts of cough, what if he develops chest pains? What do you suspect?
Post-acute
Anybody? Fracture of
What
the
are the
ribs,
complications of severe cough?
isn't it?
Yes.
Okay. A patient has got chronic cough, severe cough. What are the complications they can have?
Let's come to that.
Complications of cough.
Chronic cough.
One is if he's expecting too much, then he could have post-recessive syncope. Sir.
Okay,
Versus syncope.
right, fair enough.
And
Then raised intracranial tension causing retinal hemorrhages, intracranial hemorrhages,
subconjunctival bleed.
subconjunctival.
Second, less common, but it's okay.
Then yes, as you said, as I mentioned, rib fractures and pneumothorax.
Even you
And hernia.
suddenly the same person suddenly comes to casualty with severe breathlessness. Possibility of pneumothorax. Okay,
Hernias, abdominal hernias.
that may not be our area. It's okay. Then and is smoker.
When do you say chronic cough?
Cough lasting for more than 8 weeks.
Chronic.
Acute is less than 3 weeks. So 3 to 8 weeks is subacute, and more than 8 weeks is
Chronic. So anyway, any cough is just start with acute only. This is more than 18 chronic cough for hours now. Definition purpose. Okay.
So
Then,
the end of
another
the
important interesting thing. That's good that you elaborated number of exacerbation last 10 years, last 1 year. What is its importance as far as COPD is concerned?
indicates the progression of the disease, sir.
And rated World 2026 guidelines is good that you have elicited them. It's good.
The importance.
One is we can categorize into A, B, and E. sir.
Categorization and management purpose.
Yes.
Okay, very good.
If he belongs to category of E, sir, if he has been a COPD, then he had at least one hospitalization, one exacerbation requiring hospitalization.
Okay, so even the treatment as for selection of treatment is very, very important.
Yes.
You can directly straight away go for triple drug therapy.
What is that drug history you take? Yes. Because one drug that may not be beneficial in this patient, more when patient has got cough, more cough, wheezing, people would prefer to write that drug. But that may not be beneficial in this particular individual. That you have to. Steroids, correct. Huh? So you are supposed to avoid that steroids because most of the time we tend to make that mistakes. Okay. Suppose it is a chronic bronchial asthma, that is a treatment. Whereas in COPD, which is the drug of choice treatment
LAMA plus LAMA combinations.
before that.
Short-acting bronchodilators.
It's only the oxygen which helps in the end stage.
Long-term.
Could it be tuberculosis itself again?
Could be a reactivation. Considering there is no history of recent increased production, recent fever. There is a loss of weight.
What do you think that might be due to? Or rather, what are the causes of loss of weight?
One could be a chronic inflammation causing reduced appetite.
Okay. But you said his appetite is normal.
Appetite is normal.
Then
Next one being a malignancy or a reaction of tuberculosis.
something more less.
Could be a reactivation. A reactivation of tuberculosis causing.
On the whole, I'm asking in respiratory disease, not necessarily in what else?
Can there be severe weight loss in COPD only?
Yes.
Simple COPD, the severe
COPD patients are known to be cachexic and
severe
due to high degree of
why?
Why?
due to high degree of inflammation, TNF alpha and IL-6, they'll suppress appetites.
Workup breathing
Is it
itself.
Breathing is more.
Workup
The
breathing.
requirement is more.
Hypermetabolic state.
Metabolic rate is more. That's why they start losing, they become sarcopenic. That's why that's our would say very important. That is okay. Next.
Causes of weight loss.
Yes. So immediately malignancy. Okay. Okay. He has got weight loss of
Weight loss of around 4 kgs, sir, in past 1 year.
do you consider it significant?
Based on the definition, it is not, sir. It comes to less than 10%.
And it's almost over 1
Duration
year.
is 1 year.
1 year,
Yes.
right?
Yes.
So then not be because the disease process itself causes weight loss. So it may not be, you need not have to bring some other etiology to answer that weight loss in this patient. Okay. And is going on and on. So many years. It may not be a significant disease. Like either infective cause for weight loss or malignancy for weight loss. Okay. So the end of the history, what is your diagnosis? Plausibly,
With significant past history of tuberculosis as well as smoking, I'd like to think this to be a case of either a post-tubercular sequelae or could be a chronic
airway disease.
chronic airway disease involving lung
It's
and
very significant.
airway and
We
parenchyma.
cannot disregard that. So chronic airway disease in the background of tuberculosis, the past. Okay.
Does there any allergic disease in the family history?
No history of
Well,
allergic substance.
you did anything about allergic disease? Any family member having any allergy, asthma, COPD?
No, he is not
Yeah,
allergic
fever.
to any.
You didn't mention anything about that.
I have mentioned patient is not
Mention,
allergic to any food
mention.
substance.
Morning, you had a class on that ACO.
We go to examination. Either diagnosis, differential diagnosis.
I'd like to think of 4 differential diagnoses. So one could be a COPD secondary to smoking,
Right.
or a post-tubercular TOPD or any other sequelae,
Right.
and occupational lung disease and malignancy.
Why not it is post-tubercular bronchiectasis?
Expectation is not too much. It's not. It's around. He
How
told
much
us
you expect?
we expect.
Too much you are telling.
Yeah, we expect it to be a bronchoria, so more than 100 ml. But in cases of bronchiectasis sicca, they could have lesser than that.
He's giving a very typical history of a long period of sputum production interspersed with decreased violence and hemoptysis. That's so it could still be it's still
Bronchiectasis, because in between, as Madam pointed out, there are sticks of hemoptysis in between. Okay, that definitely goes in favor of suppurative lung disease, especially.
What are occupational lung diseases do you know of? Especially farmers. Forget about cooling.
Bagasosis and bicinosis. Bagasosis because of sugarcane and bicinosis due to cotton exposure.
All occupational just mentioned for the sake
Bird
of
fanciest.
Exposure to chemicals, including your poison, everything. Bacterial infection, bacterial antigen exposure from bacteria, fungi, everything, including toxins.
Asbestosis, silicosis,
including
pneumoconiosis,
everything mentioned step by step.
Cold-worker pneumoconiosis, asbestosis, silicosis,
Starting from farmers lung.
silicosis.
Farmers lung.
Yes,
Hypersensitive pneumonitis. Only they are commonly involved with that. Yes, sir. Starting from that, there are 10, 20 cases. At least tell me 10 commonest.
This hypersensitive pneumonitis.
Okay.
Then
what is the causative organism? Antigen from bacteria actually. Thermo.
Chinotophomonas.
Anybody? Actinomycetes.
Thermoactinomyces.
Which is the commonest? Bacteriitis. Antigen from bacteriitis, not fungus. Farmers lung is the causative. Hypersensitive pneumonitis. Which is from respiratory medicine.
So there is a culprit.
ವಾಯ್ಸ್ ಸರಿಯಾಗಿ ಕೇಳಿಸಲ್ಲ ಏನೋ ಇನ್ನೋವೇಟಿವ್ ಮಾಡಿದ್ರು ಸಾಕು
Shidhar, could you please stop?
ಏನ್ ಕೊಡ್ದೇನಪ್ಪ ಅಣ್ಣ ನೋಡೇ ಬತ್ತಾ ವಾರ್ಡ್ ಬಾಯ್ ಕಾಣ್ತಾ ಇದಾನೆ ಓ ಸರಿ ಸರಿ
Pigeon breeders lung.
Bird fanciest disease. Bird fanciest disease.
That's also hypersensitive pneumonitis. These are occupation related. Okay, go ahead.
The physical examination, he is an elderly male, moderately built and malnourished, oriented to time place in person. Height is 166.
So you have to keep many things before examining the patient. So you thought of a chronic bronchiectasis, post-tubercular bronchiectasis, chronic airway disease. What else you can do that?
Occupational lung disease.
So these things in your mind. So you have to examine the general physical examination as before we go for a system examination. Okay. What specific things you would like to examine in this? Because on the background of the 3-4 diseases that you have considered historical diseases.
I'd like to look for signs of respiratory failure, sir. For signs of any external markers of tuberculosis. For if he is sick, if his BMI is low, if he has any clubbing, if he has pedal edema, signs of right heart failure.
So PGs, keep in mind, when you're saying someone is moderately built and nourished, you're not just sticking, you should also mention by the other signs of malnutrition, vitamin and trace element malnutrition, especially in a man who has a. So are there any other features? Glossitis, knuckle hyperpigmentation, pallor itself. Is anything else there?
No, ma'am. Except for graying of hair, there are no other signs of age related. Nothing else. No pallor, no itching, no cyanosis. Grade 3 distal clubbing present in all fingers of bilateral upper limbs. No lymphadenopathy, no bleeding.
So the minute you saw this, which two possibilities go higher up in the list of your differentials? The minute you saw the clubbing?
Bronchitis,
And?
respiratory disease. And
Malignancy, isn't it?
yeah, there's ring of hairs, nicotine staining of teeth is present, dental caries are present. No external markers of tuberculosis or malignancy. There's no external markers of respiratory failure.
Because of malignancy, are you looking?
One is any hard lymph nodes or
Where?
particularly supraclavicular lymph nodes, internal malignancy
Internal malignancy of what?
of JS, gastrointestinal.
You are suspecting GA tract because there are no symptoms of GA malignancy. As such.
The occult malignancy causing lung mets.
What are the external markers of tuberculosis you would like to look for?
Starting from head to toe, in the eye, I'd like to look for choroid tubercle,
Okay.
any granulomatous uveitis, or then I like to look for lupus vulgaris, and then scrophulodoma, and
Yes,
erythema nodosum, bitter vas deferens, matted lymph nodes.
Before writing all those no external markers of malignancy, tuberculosis, you should be confident enough to say what is no there, what is yes there. Then only you should mention. Otherwise, better not to commit there. Yeah. No, you should be knowing what are the markers. What are the markers. So if you don't know, then why do you commit there? That is what happens in exams. So simply you write, it is not a protocol that you should write out.
Avoid blanket statements.
Yes.
Not two things.
That's all.
Pulse was 84 beats per minute, regular rhythm, normal volume and character, no arterial wall thickening, no radioradial or radiofemoral delay, or peripheral pulses were well felt. Blood pressure 110 by 70 millimeters of mercury, right arm sitting position. Respiratory rate was 18 beats per minute, abdominal thoracic type. Saturation was 96% at room air. JVP was 2 centimeter posterior angle at 45 degrees position.
Importance of BP measurement, all the things that can go wrong with blood pressure in a respiratory case, basically.
Could be a secondary heart failure, corpulmonal causing.
Is that what you want to say first? Respiratory case with hypotension, what do you think first?
Tension pneumothorax.
Okay, that's an okay answer then. What else?
Then
Atrial fibrillation, MAT, causing hypertension.
Why don't you think a respiratory disease which you see fairly commonly, does it come as part of any score?
Curve 65 score.
Hmm.
Blood pressure, sepsis, a severe pneumonia could cause hypertension.
Any other cause? Especially in a man like this with this past history, hypertension, what would you think?
post tubercular, long term.
Adrenal crisis,
Renal insufficiency.
adrenal failure.
What do you expect in the pulse? Suppose it is a long term chronic COPD.
If he has a type 2 respiratory failure, pulse for volume would be bounding, sir. Then if he has
Especially if they have type 2 respiratory.
type 2 respiratory,
PCO2 is more.
PCO2 is retention.
Why you get a bounding pulse?
Because of the warm peripheries, PCO2 will cause
Why the
vasodilation.
peripheries are warm?
Raised CO2.
CO2 is a powerful vasodilator.
vasodilator.
That's the reason why. Okay.
What is pulsus paradoxus? Whole time we were taught that that's an indicator to assess severity of asthma. No more it's used.
Respiratory fall in BP by more than 10 millimeters of mercury.
You know how to measure it.
Yes. We wet the cough until the until we stop hearing the sound, until the pulse is absent. Then we start deflating. Initially, we hear pulses only during the expirations. Later, we start hearing correct sounds in both inspiration and expiration. The difference, if it's more than 10, then it's
What rhythm abnormality you expect in the background of this function?
one. If the patient is COPD, then he's at risk of MATs, multifocal atrial tachycardia. So he could have a regular.
Next rhythm abnormality is MAT. Then
Atrial fibrillation.
any type of
Any other
you can see.
Atrial tachycardia.
Regulations.
Respiratory system, respiratory system, there's no sinus tenderness, no DNS, no polyp, no nasal discharge. Nasal mucosa was normal. There's no turbinate hypertrophy. Oral cavity, he had a poor oral hygiene with dental caries. Our posterior pharyngeal wall was normal.
What is the importance of examining upper respiratory tract in a patient who has a chronic airway disease?
Sinus tenderness indicates sinusitis, could be a part of cardiogenic syndrome. So, say ciliary dyskinesia. The polyps indicates ethmoidal polyps is a part of aspirin sensitivity syndrome. Allergy.
Polyps can be allergic. So same way they could have allergic airway disease. Okay. Yeah.
Chest syndrome.
Yes.
Could,
So
was
any poor rental
ulcers.
aspiration pneumonias and suppurative lung disease.
Respiratory disorders.
Sinusitis, chronic sinusitis.
If he has a PND as a cause of chronic cough, then posterior pharyngeal wall would be covered with the nasal discharge. Yeah. Lower respiratory tract, chest is abnormal in shape. It's alar, anteroposteriorly flattened. Symmetry is noted in the form of right infraclavicular retraction or hollowing with the drooping of right shoulder downward, and also there's downward displacement of right inferior angle of the scapula. Apical impulse is not visualized. Trachea appears to be deviated to right. Trail sign is positive on the right side. There is mild thoracic spine scoliosis to the right.
Any final year PG, can you come and demonstrate correctly palpation of trachea since we got the patient?
Yeah. Any other MMC? Call your friend. Yeah, no problem.
Instruction given is examine the trachea, not palpate the trachea. Do it correctly as if passing the exam depends upon it.
Yes.
What up?
Video cam. Hello. Yes. Yeah. You just do it.
Or want them in advance and ask for permission. Huh? Otherwise, it gets scared. Really?
No. What are the three basic F's in your exam? Spread. First, fix the head. Then flex it. Then feel. These are the three F's you should follow while you are palpating to examining for the patient. Visualize that. Focus, Madi.
This sign, it's always nice to stand directly in front of the patient. Now I understand because of the camera you're standing. But actually you should stand in front.
Now we can palpate.
3-finger followed by 2-finger method. 3-finger, what do you do? 3-finger method. Yes. Don't poke, man. You run your hand out gently. Don't poke. No, I don't. So use your middle finger to run down the string.
To trace it properly.
Let's follow the medium steps. Yes. Gently. Then can easily, yes. Left side is able to place it easily. Right side, yes, difficulty. Most it feels resistance, right? Okay. Tracheostomy, we went to the right side. Decreased tracheosternum distance on the right side. Thank you, doctor. Yes. So all of you can visualize here the tracheostomy. Okay. Go ahead. PPT. There's no usage of accessory respiratory muscles. There's no intercostal retraction. There are no visible pulsations, scars, or sinuses. Chest movements on inspection, the supraclavicular, infraclavicular, axillary, and suprascapular movements are reduced on the right side. On palpation, trachea is shifted to right. Inferior angle of scapula is displaced 2 cm downwards compared to the left. Apex peak is felt in the left fifth intercostal space, middle to mid-clavicular vein. Tactile firmity is felt over the right infraclavicular and mammary area, which is palpable crepitations were felt over the mammary area. There was no local rise of temperature, no tenderness, no rib crowding, no subcutaneous emphysema. Chest movements, even on palpation, it was reduced on supraclavicular, infraclavicular, axillary, and suprascapular areas. In other parts, it was normal. Measurements, the transverse diameter was 20 centimeters, AP diameter was 11 centimeters, the ratio was 1.8. Spinoscapular distance was on the right side, it is decreased due to shoulder toping. It's 10 centimeters on the right side, 11 centimeters on the left. Spinoacromial distance, however, was increased on the right side, again due to lateral bulging of the shoulder, lateral bulging of the scapula causing increased spinoacromial distance. On the right, there is 21 centimeter. On the left, it's 20 centimeter. Chest circumference, on inspiration it was 85 centimeter, expiration 83 centimeter, expansion was 2 centimeter. Right hemithorax measured 41 centimeter on inspiration, 40.5 on expiration. There was a reduced expansion compared to left of around 0.5 centimeter. Left hemithorax, however, was increased compared to right, 44 centimeter, 42.5 centimeter on inspiration, and expansion was 1.5 centimeter. The end of palpation, what's your GRAS diagnosis? At the end of palpation, I would like to think of. Did not give a particular. So, what do you think? There are signs of the right hemithorax compared to the left. There are signs of volume loss in right upper hemithorax. Correct. So, evidence of volume loss. Right. With upper mediastinal shift.
So the beauty of respiratory system is this. Just with this information, you can come very, very close to your diagnosis. So PGs, the minute you see a patient, most likely the respiratory disease you get in the exam is going to be unilateral unless it's ILD. Acute cases we can't give. So the side which moves less is the side of the disease. So now we've decided it's on the right. The second thing you notice is the trachea shifted to the side which moves less or away. Here it's very clearly shifted to the side of the disease. So what are the only two possibilities?
Fibrosis or collapse.
And with the past history, it's a fairly academic exercise just going ahead, isn't it? Because we'll know the diagnosis by this point. So if I could give you a hint for the exam, students, all of you stand at the foot of the bed for half a minute to a minute and just observe these three things, especially chest movement. Half the battle is won with chest movement and tracheal position.
Firmity, it was increased on right supraclavicular, infraclavicular, axillary, and suprascapular area. Percussion note was impaired in supraclavicular, clavicular, infraclavicular, axillary, and suprascapular. Impaired percussion note. The chronic systems, the right side was impaired note, left side was resonant. Top space was tympanic, and tidal percussion was positive. It's, previously, dull note became resonant after deep inspiration. It indicates the dullness is supradiaphragmatic or subpulmonic. What about chronic isthmus? How do you interpret that? Chronic isthmus impaired on the right side indicates fibrosis of the apex. Or if the resonance of the band of the resonance width is increased, then it could be hyperinflation of the lungs. So dullness. there is impaired.
Particularly, probably which segment of the lung is involved? Chronic issues. Apical segment.
Upper lobe apex. Character of the breath sound, there's a cavernous breath sound in supraclavicular, infraclavicular, and axillary areas, and also in the suprascapular area. In all other areas, vesicular breath sounds were heard. Intensity of the breath sound was increased in supraclavicular, infraclavicular, and axillary, as well as suprascapular area. Added sounds were bilateral, especially in the anterior chest wall. There was fine early to mid inspirated crepitations with occasional polyphonic bronchi in right supraclavicular, infraclavicular, and also in the left supra and infraclavicular, as well as in mammary area.
Do you feel there are fine crepitations?
They are fine.
Fine crepitations generally which phase of respiration will they occur? At what part?
Late inspiratory crepitations. But I feel early, major bronchus were involved now. So that was causing
especially
proximal airways were involved.
Right interscapular area, it is fairly coarse crackers only. Okay, so that could be subjective, but the timing at least is not very typical of fine crepitations, isn't it?
And again, bilaterally, there were early to mid inspiratory crepitations with occasional polyphony. Vocal resonance was again compared to vocal film test was increased on supraclavicular, infraclavicular, axillary, and suprascapular areas. In auscultation, there was bronchophony, egophony, and whispering pectorally present over the right supraclavicular, infraclavicular, and axillary and suprascapular area. Also, there was post-testive suction as well as post-testive crepitations heard over the right supraclavicular, infraclavicular, axillary, and suprascapular.
What is that post-testive suction? How do you interpret that finding of post-testive suction heard over the right supraclavicular, infraclavicular, and that to a wide area? Because supraclavicular, infraclavicular, axillary, and supra. So almost right upper lobe is wide area. Do you get post-testive? Where do you get the classically post-testive suction?
Superficial thin-walled collapsible cavities in active tuberculosis.
So you need to have a large
cavity communicating with bronchus.
That is most important. You should have a communicating bronchus. Then why do you get that post-testive suction sound? What is the suction sound heard is due to the
inspirations. Because of the inspirations, the cavity collapsed.
Once you cough, what happens? It clears off the secretions. So then there is suddenly an opening. So there will be a gush of air into the cavity. So that is what the suction sound you hear following a cough. That's a classical sign of cavity, tubercular cavity. It's a large, superficial,
thin-walled
cavity communicating with the bronchus. Then only you get this sign. Not every cavity will give this sign. Don't think that you get all tubercular cavity, you will get this clinical sign. It should be a large cavity. It should be a superficial cavity. And third point, it should be communicating with the bronchus. Then only you get this sign. Otherwise, you don't get. And suppose when you get this post-testive suction, what you should have concentrated while percussion?
Should have been a tympanic note on percussion. Crackpot resonance.
That is, you will answer crackpot resonance. What is that?
A tympanic note on, well, tympanic note when we percuss over large cavities.
Yeah, that too, then you get only in communicating with the bronchus. So if you percuss over a earthen part with a large in particularly mouth. So that's why you get that crackpot resonance. Otherwise, you don't get all these things. Probably all these classical explanations were given when I was doing post-and sir was doing post-graduation, then tuberculosis were rampant. Patient used to come in an end stage. We have seen such. Probably nowadays, I don't think any of the students have seen these signs. I don't think.
Yes, let's examine this case. What is it?
Yeah, at least because it's
You
an
can just come and auscultate.
But auscultate at least.
Everybody wants to contribute his findings. He's telling you could hear 5 trips. Quite obviously a lot of core scripts. And then I think we'll go for basics. How do you differentiate fine and core scripts? Where do you get fine scripts?
Not coming like.
Where do you get core scripts? How do you differentiate between fine and core scripts?
Your
Causes for
walking
fine and
itself
core
shows
scripts.
that you are not confident. So always, whether you know or not in exam, you should walk confidently.
Okay, sir, but yes.
Talk confidently. That is the most important as a physician.
Next
When a
question.
patient comes to you, you should be a confident doctor.
Where do you hear fine scripts and where do you hear core scripts?
What is this?
Fine trips are heard because of the sudden snapping opening of collapsed airways.
Good.
And fine trips are
And
heard
there is
because of
the
passage.
equalization of pressure across the terminal airways. Bronchioles are collapse, opening up of collapse airways. Alveoli. Okay.
And core trips are because of when the air passes, bubbling of air when it passes through the secretions.
Good.
Then fine trips are heard in interstitial lung disease, early phases of pneumonia, early phases of heart failure, hypersensitive pneumonitis, sarcoidosis, asbestosis.
Early part.
And core steps are heard in redux crepitations or resolving phase of pneumonia, bronchiectasis, tuberculosis.
See, a case like this, it hinges on your findings. So findings should be correct. And even if you have a doubt, no, there are many things if you're not sure of. So if you're not sure about the quality of practice,
Ask the patient to cough. It will change.
that's one thing. And plus there's clubbing, which might be bronchitis, plus the location of the crackles.
So what's your time?
Ask the patient to cough and ask her to it again.
Crackles. Is it fine crackles?
Fine and coarse.
Fine. There's something wrong with you guys. Fine cracks is
Yes,
only
sir,
if you are
speaks.
hearing
Yes.
the creptation at the end of inspiration. That's the timing is most
That's
important.
fine. That is fine.
Saying the
End of
crackles,
inspiration.
both inspiration and expiration, is not fine crack.
Right. Want to really hear fine steps? Velcro, there are many cases in ward now. You can go and ask her to try the creps.
There were actually palpable crepitations which could indicate there were coarse crepitations. But him being a thin built with AP flattening, I thought it could be because of his cachexia causing the palpable crepitations rather than.
Anything, the crackles
Fine.
which starts with inspiration, it cannot be a fine crack.
Indicates. What does
The end of
post-test
inspiration
suction
probably-
indicate? You said post-test suction is present. Yes. What does it
It
indicate?
indicates that the cavity is communicating with bronchus.
So you are suspecting cavity there along with fibrosis.
Why is it? What are the other possibilities? Okay, post-test suction. It's only tubercular cavity or any other cavity. You said cavernous breathing. So there can be so many other causes from cavernous breathing. That too, when you're talking about post-test section.
Bronchopleural fistula is one TDs.
Yeah. So,
But he will be having large amount of sputum productions. Patient will be sick. He would be febrile.
no, it is- what are the other conditions? Right.
Post-tessive suction is classical of cavities.
All the three should be there. So it should be large, it should be superficial, and it should be communicating with the bronchus.
Post-tessive suction as well as complications with cardiovascular examination. Significant precordial bulge was absent of ankle.
So what do you, with what specific intent you want to examine the cardiovascular exam in this particular individual?
I would like to.
What do you expect? Actually, what do you expect actually? What do you expect actually?
But expect if him being a chronic disease, I would like to expect parasternal heave, a loud P2, or
You
raised
like to
AVP.
examine the left second space, looking for the loud P2, view.
Precordial
Since
bulge
there is-
doesn't make sense here, no, in this case.
Since there is a history, there is volume signs of volume loss on the right side. There could be a shift in the apex. However, only upper mediastinum was shifted.
One second. You didn't look anything that
abdomen?
you saw?
Don't want to see the abdomen. Patient has got a chronic cough, so many years, and he's coughing and he's producing sputum. You don't want to examine the abdomen.
Earlier orifice is normal.
You should look for.
Earlier
he
orifice
has-
was, yes.
Apart from
Anything
that,
else?
he's
Anything else?
losing a lot of cough with expectoration. What else you
Anyone
should
else?
see? Any other organ you want to palpate in the abdomen?
Any other
Chronic
organ and why?
respiratory disease?
Situs inversus.
No,
Oh, no.
I'm saying in this case only, but
case
usually this. Anything else and why?
You want to examine the spleen? For what?
Amyloidosis, yes, correct.
Did you look for the sign? You mentioned no signs of respiratory failure, but did you look for a flap?
No flaps, no.
ಇಲ್ಲ ಯೂಟರ್ನ್ ಯೂಟರ್ನ್ ಇಲ್ಲ ಇಲ್ಲಪ್ಪ ನೀನು ಆಗ ಯೂಟರ್ನ್ ತಗೋಪ್ಪ.
ಅದೇ ನಾನು ಅದೇ ಅಂದಿದ್ದು ಆ ಸೈಡ್ ಬಿಡ್ಬೇಕಂದ್ರೆ
ಇಲ್ಲೇ ಅಂತಿದ್ದು ತಗೋಪ್ಪ.
Mute all those people who are online. Yes, universal mute. Okay. Okay.
Diagnosis to be a case of right upper lobe fibrosis with gravitational lesion and communicating with nodes, like a sequelae of tuberculosis with bilateral obstructive pulmonary disease. Since there were very fine X-ray, I felt it was a very bad sign. Make a diagnosis of bronchitis, not in carbonal and not in respiratory phase.
Like a diagnosis of bronchitis, you still have to explain the clubbing.
Clubbing could be due to hypoxia, chronic hypoxia causing.
Does he have hypoxia evidence?
Not at present, sir, but during exacerbation he was hypoxic.
Yeah.
Clubbing.
Harrison gives COPD as one of the cause for clubbing. It's okay.
How would you like to proceed? Oh, okay, let's see.
So,
yes,
plain chest X-ray PAV with adequate exposure, showing a non-homogeneous with a tracheal shift to a right side with a non-homogeneous opacity involving the right upper limb with signs of right upper lobe. Sorry, right upper lobe.
There is nothing in the left.
There are non-homogeneous opacities involving the right left upper lobe.
What else?
There
has happened to the hilum? Hilum is pulled up, no? It is not in the regular portion. So there's a pulled up of the hilum. And even there is fibrotic band in the left. So when you are talking the X-ray, we're talking zone, upper zone, mid zone, and lower zone. As a clinical examination, upper lobe, middle lobe, and lower lobe on the right side, left upper lobe and lower lobe. Right. Just exam X-ray, you should always zone.
The mucovascular markings on the lower lobe are compensatory.
What has happened to the lower zones?
Lower zones, yes, sir. There is compensatory hyperinflations.
Okay. What else is there?
With widening of intercostal space. With
oh, of course, X-ray may be poor. HRCT may give us a better diagnosis, but still you have some lesions, bilateral, some areas, tubular areas, bronchiectasis. They are all bronchiectasis changes. Yeah. Yeah, what has happened to the cardiophrenic angle? Right side. Even almost is equal now. Normally, right is then it. So there is the raising of the diaphragm.
Yes.
Okay.
Down.
So COPD.
Yes.
Push down there. Okay. That's what we call as terracing of the diaphragm.
ಒಂದು ನಿಮಿಷ ಬನ್ನಿ ಕೂತ್ಕೊಳ್ಳಿ. ಯಾರು ಪೇಷಂಟ್ ಫಸ್ಟ್ ನೀವು ಬನ್ನಮ್ಮ.
Calculate the height of the diaphragm from cardiophrenic angle to
the dome of the
diaphragm. From this angle to this angle, it should be more than 1.5 centimeter. It's hardly not even 1 centimeter. You just calculate that, just measure that. This angle, it almost not even 1 centimeter. So it's flat. Actually, there is compensated hypertrophy of,
inflation.
Hyperinflation is there. Yes. Both the lungs. Examination also you missed it actually. We didn't examine it properly. We missed that actually. So bilateral upper lobe extensive fibrosis, fibrocavity, compensated hypertrophy of both the lower lobes are there. Even if you look at the lips, about they're horizontal. They're not slanting. Wide and intercostal space are there.
Okay.
Almost flat diaphragm.
Note was still resonant in the lower lobes.
Maybe it's hyper-resonant actually, rather than resonant. Because if you go back and
because upper lobe being impaired, thought lower lobe was resonant.
So okay. Compensatory emphasis.
Chastity Findings were cicatricial fibrocavity interchanges with tractional, cystic, and varicoid bronchiectasis, with few calcifications in upper lobe of both the lungs and middle lobe of right lung, with the largest cavity measuring almost 3 centimeters in apical segment of right lung, with collapse of upper lobes of both the lungs and middle lobe of right lung, with compensatory inflammation in hyperinflation of lower lobes of both the lungs, with mild tracheal shift to right, with fibrotic bands noted in both the segments. There was no evidence of any mediastinal shift. Costophenic recesses were free on both the sides. Impression of cicatricial fibrocavitary changes.
So most of the findings we got in chest X-ray itself. Of course, this has added some more fine
videos.
Okay.
So the cavity.
Okay, on the right side.
What discharge advice would you give him? What all would you do so he doesn't come again and again with repeated exercise?
One is I'd like to give advise him annual influenza vaccinations. Wear a mask.
Before that, quit smoking. Exactly. Stop smoking.
Stop smoking. Most important. And avoid exposure to other things. The third one is definitely to give vaccinations. This
nutrition also.
Nutrition, you have to take care of that. Is most important. We always tend to neglect the physicians. Don't advise them properly. Proper nutrition is protein rich food. It's most important. And vaccination. Which is the vaccination you want to give? Influenza and pneumococcal vaccination. It's fair enough. I think we should congratulate him.
Good presentation.
Both in history as well as examination will almost reach the diagnosis what the chest X-ray and ICP has given. So clinical examination history is very important. That will definitely take us to the clinical examination. If you do a pertinent, proper clinical examination, you will get the diagnosis. Only chest X-ray and HRCT probably will not fine-tune your diagnosis. It may not change the initial diagnosis. Thank you.
Thank you, sir.
Thank you, Dr. Sharon and respected chairperson. Now, I request Dr. Sunita DK, Professor and HOD of Emergency Medicine, AIIMS, Vellore, to present a token of gratitude to the chairpersons. Our last clinical case discussion on abdomen will be presented by Dr. Rupesh R, third year postgraduate, General Medicine, JSSMC. I request Dr. Manthappa and Professor and Vice Principal, JSSMC, Dr. Rekha MC, HOD of Medicine, MIMS Mandya, and Dr. Krishna Murthy HA, Professor of Medicine, MMCRI, to chair the session.
Last time, what
last yeah, last one night I'm not that's the word.
Discussion today is abdomen case. So details: patient Mr. J, age 50 years, male, already diagnosed by occupation from Srirangapatna. Informant of self and wife and reliability was good. Patient came with chief complaints of increase in swelling of both the lower limbs since 15 days, abdominal distension since 15 days, and yellowish discoloration of the eyes since 15 days. History of presenting illness. Patient was in his usual state of health 6 months ago when he developed swelling of both his both his legs, which was insidious in onset and Initially only up to the level of the ankles. Following that, it gradually progressed and increased up to the level of the knee since the past 2 weeks. And patient also noticed the swelling increase as the day progressed, and it decreased on placing the both legs in elevated position on a pillow. It was not associated with redness or pain in the left lower limb, but there is history of pain and discharge from the right lower limb since the past 1 week. Patient then noticed distension of abdomen since 30 days, which was insidious in onset and progressively increased to reach the current stage. It was associated with heaviness that was unrelated to food intake. There was no associated breathlessness. There's no associated pain abdomen. The patient also noticed history of yellowish discoloration of eyes since past 2 weeks. It was not associated with high colored urine, pale colored stools, or generalized itching. There was no history of yellowish discoloration of skin, no history of fever, pain abdomen, nausea, vomiting, no history of passage of black tarry stools or fresh blood in stools. There was no history of decreased urine output, frothy urine, or periorbital puffiness. No history of chest pain, palpitation, shortness of breath. No history of native medication intake. No history of previous blood transfusion. No history of increased daytime sleepiness or altered sensory. Patient is not a known case of diabetes mellitus, hypertension, heart disease, stroke, thyroid or seizure disorder. Past history is recently admitted a month ago for the same complaints in Radiant Hospital. No history of tuberculosis or exposure to TB in the past. There's no other significant past history, no surgical history. Personal history: patient consumes a vegetarian diet. There's no recent change in sleeping pattern, no excess daytime sleepiness. There's no loss of appetite. Patient gives history of weight gain since the past 2 weeks in the form of shirts becoming very tight at the level of the abdomen. There's no alteration in bladder habits, and passes stools twice a day. It's normal in consistency. There is history of alcohol consumption around 270 ml of whiskey per day, every day for the past 18 years. His last thing was 6 months ago. Daily intake is around 108 grams of alcohol. Patient is a chronic smoker, smokes around 3 to 4 cigarettes per day since the past 15 years. That comes around 4.5 pack years. There's no history of tobacco chewing. Family history: he's the second one out of non-consanguineous marriage. Patient has no children. Father died of a heart disease at the age of 40 years. Mother died at the age of 69 about a year ago. She had some respiratory issue, very asthma. Patient is not sure. There's no history of liver disease in the family.
At this point, in the history, have you taken the history of blood transfusion or history of travel?
Blood transfusion I've taken. There is no history of blood transfusion in the past. To summarize, we have a 50-year-old male with no known comorbidities with a significant history of alcohol consumption since the past 15 years. With common progressive swelling of bilateral lower limbs in 6 months, abdominal distension since 30 days, and yellowish discoloration of eyes since past 2 weeks, with no history suggestive of variceal bleed or hepatic encephalopathy. So I'd like to think of decompensated chronic liver disease, likely secondary to alcohol, not in hepatic encephalopathy, and probably right lower limb cellulitis.
Okay, anyway, from the history, straightforward diagnosis is alcoholic liver disease. But just for discussion purpose, go back to the first slide. Some symptom analysis for the use of everyone. So increase in swelling of both the legs since 15 days. So can you tell some cause of bilateral and then unilateral leg swelling?
So bilateral right heart failure, chronic liver disease, chronic kidney disease, nephrotic syndrome, protein losing enteropathy, hypoalbuminemia, anything goes in.
Then distension of abdomen since 15 days. Can you tell some cause of death?
So we have like 7 Fs: fat, flatus, feces, fetus.
Yellowish discoloration also since 15 days. All started at one point of time.
The swelling of lower limbs was there since 6 months, but it's progressive. It is increased since 15 days. What brought the patient to the hospital was this worsening abdominal distension and yellowish discoloration. I have mentioned it as 15 days, but the swelling of lower limbs was there since 6 months.
The past history you written swelling of limbs in 6 months, yes, no?
Yes, sir.
Since 6 months swelling of limbs, after that, okay, abdominal distension, later on yellowish discoloration and eyes. Still you want to think of liver is the first possibility here? Why? So how do they present? In case of liver disease, liver involvement, cirrhosis of liver, how do they present?
Usually abdominal
distension first and afterwards swelling of limbs. Yeah, that's how it comes. Here swelling of limbs first, afterwards distension of abdomen, along with jaundice. Still, you want to think of liver is the first possibility here?
Think of heart disease as well.
And that distension is only 15 days. If at all, if you think of cirrhosis, it's a chronic condition. What should be the duration of history?
within 6 months.
6 months. Here only 15 days. Still you want to think of liver disease?
Be acute decompensation. Liver disease might have been compensated until now and would have
But patient is not having any history of distillation abdomen before 15 days. Still you want to think of liver now?
Okay, if you think of just because lower limb swelling appeared first, so you can think of cardiac disease. But by thinking of cardiac disease, can you explain jaundice? All the three.
Yeah, all the three. Can you
Jaundice,
explain?
abdominal distension, swelling of legs.
In right heart failure, you can have swelling of lower limbs. You can have abdominal distension, hepatomegaly.
Okay.
And you can have, because of that, secondly, you can have.
What is that condition called?
Cardiac cirrhosis.
Cardiac cirrhosis. Cardiac cirrhosis takes years. No, is it due to hepatic congestion?
Without cirrhosis, can they have jaundice? Without cirrhosis.
Congestive.
Congestive.
Congestive. Okay. In any cardiac disease, alcohol related, can you think of some cardiac condition which can present with all this?
Dilated cardiomyopathy.
Dilated cardiomyopathy.
Yeah, if you want to think of dilated cardiomyopathy, so see, is there in left side chambers involvement here?
There's no breathlessness.
Yeah, that's why you can't think of. So it may not be due to alcohol-related cardiomyopathies. Everything, all features, if you want to take, it has to be to the right side chambers involvement. Yes, no distension, swelling of limbs, and also. Okay, so the CLS discoloration of eyes you can think of with the right side chambers involvement. But so in case of alcohol-associated cardiomyopathy, they will have bilateral. Yes, no, usually left side and later on actually so right side also can get affected. So can you think of that possibility now?
Left side
Heart failure leading into congestive hepatomegaly and ascites
can also be a cause.
So there is another possibility. Where do you get which cardiac disease will produce ascites first? Usually lower limb swelling appears first. But exceptions are there. Where do you get?
Ascites precox.
Yeah.
Constrictive pericarditis.
Constrictive pericarditis are rapidly developing. Very rapid development of heart failure. Okay, go ahead. Next.
Should I elaborate on this?
So what other possibilities you can think of here?
They say that still primarily to think of chronic liver disease, but it can be right heart failure. Patient is also a smoker, maybe but no respiratory symptoms otherwise. Just an
Possibility you keep liver disease only, but as a differential diagnosis, you can keep cardiac disease still. It's a second possibility because lower limb swelling appeared first. For that reason, you can keep cardiac disease as second possibility, but still it appears to be like liver disease, alcohol-related liver disease. So history of pain discharge from right lower limb since 1 week. So what could have happened here?
So there would have been pre-existing swelling over that. Some infection would have happened from leading to cellulitis.
Look at the next slide.
Abdominal distension was since 15 days, which is insidious progressive reached the current stage. And there was associated heaviness, but no breathlessness or pain. So unlikely to be SPP at the level of history.
What is SBP?
Spontaneous bacterial peritonitis.
What's the count?
Total counts more than 250. The patient of liver disease having fever or pain abdomen, or any cause for any patient presenting with decompensation, we have to rule out spontaneous bacteria.
See, if you so take only ascites. Okay, so based on that, 6 months ascites is there. 6 months swelling is there, 1 month ascites is there. Can you think of tuberculosis here, tubercular abdomen?
There would be usually fever or some other stay as well.
Fever will be there, then what else? How do you differentiate tubercular ascites from ascites due to cirrhosis?
They might have loss of weight and
yes,
tuberculosis,
loss of weight, loss of appetite, yes.
Constitutional symptoms.
Loss of weight, loss of appetite, and also evening result temperature goes in favor of tuberculosis instead of cirrhosis. Usually in cirrhosis, they will gain weight. With loss of appetite because of fluid retention, they will start having weight gain. Yes, that's a point which you differentiate.
So what is the significance of this pain abdomen? Not associated with pain abdomen. Suppose it was associated with pain abdomen. Possibilities. One is SPP.
Other ascites still can have a drag of the peritoneum. Peritoneal drag can cause some pain.
Okay, not in this context. Any other context. Okay, distension of abdomen with pain. Can you think of some differential diagnosis? Not in this case, person.
Eccentric ischemia.
But the distension will not come. Any acute causes?
Obstruction.
Intestinal obstruction. Intestinal obstruction. Other than this, can you think of any other cause of abdominal distension, jaundice, lower limb swelling? Forget about cardiac disease, liver disease. Any other intra-abdominal cause?
Acute budget,
Elderly person.
malignancy.
Yeah. So how will you cause all this? Jaundice, abdominal distension, lower limb swelling.
Could be primary malignancy or spreading to the liver, or primary
Yeah.
liver
So
malignancy.
intra-abdominal malignancy can spread to liver, producing jaundice. It can also pressure IVC. IVC producing lower limb swelling. Any other possibility? Pain abdomen, abdominal distension, jaundice, may not be lower limb swelling. Alcohol, or either chronic alcohol.
Chronic hepatitis.
Any other organ involved other than liver? Pancreatitis. Okay. So how does it lead to jaundice? Pancreatitis. It can lead to pancreatic ascites. Jaundice? Yeah, correct. Somebody is telling, no? Obstruction. If the pancreas gets swollen, it can cause compression of bile duct. It can lead to jaundice.
What is the pathophysiology of ascites in cirrhosis?
So there is portal hypertension, cirrhosis.
What are the theories of ascites? Theories of ascites in cirrhosis.
Overfilling theory, underfilling theory.
What is forward flow theory, underfilling theory, overfilling theory?
Okay, go to next slide.
Negative history.
Underfilling theory means that is because of increasing portal venous pressure, there is decrease in the intravascular volume. So there will be activation of RAS mechanism that causes salt and water tension. That is underfilling theory. Overfilling theory is primary renal salt retain. No. So there is salt retain, primary renal salt absorption or else retaining in the intravascular space that causes increase in the intravascular volume and cause leaking of the fluid into the interstitial space and also peritoneal cavity. And forward flow theory is that is due to increase in the portal venous pressure. It starts actually so causing increase in the pressure inside the portal veins and it leads into that is capillary leak, that is especially lymphatic leak into the interstitium and also peritoneal cavity. That's how it causes it. This is called as forward flow theory, underfilling theory, and overfilling theory.
So Boyce passage of black tarry stools and fresh blood. So what are the significance of
Black tarry stools, melena, fresh blood could be hematochezia. Secondly, variceal bleed.
What are the cause for black tarry stool?
It could be upper GI bleed.
Yes.
Patient taking iron-rich diet.
Yes, then.
Excessive chocolate, cookies.
Okay, how to differentiate that iron induced black tarry stool versus blood induced black tarry stool?
The consistency, usually in black tarry stool, it will stick to the bottom of the
sticky. Stickiness will be there in case of blood induced, black tarry stool and also it's whole spilling. But in case of iron induced, that is non-sticky. Yes.
the usage of
Bismuth, licorice also.
Also charcoal.
Yeah, charcoal in case of pipings, they do. Licorice consumption, bismuth consumption, all this can lead into black color stool.
So in a chronic alcoholic like this, so black tarry stool can mean also other things, not only varicose bleeding. So other possibilities in alcoholic, any other thing can cause upper GI bleed other than varices. Associated with
malady
upper pain abdomen.
Malady is still present with
Malady is this one, no? Vomiting or retching before the onset of any other pain abdomen, upper pain abdomen, melena, peptic ulcer. Alcoholic are more prone to peptic ulcer. So if they have melena, they did not always have varices.
What history you will take?
Pain abdomen, which is just immediately on taking food. Usually in duodenal ulcer, it's few hours after taking consumption of food, and gastric ulcer is usually immediately on pain. Usually in epigastric.
You're passing fresh blood in the stool indicates what?
Hematochezia.
Due to what? Here in this case, with respect to this case.
Rectal hemorrhoids.
What is it? Is it due to portal hypertension? Portal systemic?
Photosystemic, you
connections,
do have
varices.
the rectum also, sir. Like esophageal varices, you also have rectal varices. So could be secondary. That could be also local causes like fissure and so.
But in this case, with respect to this case, if you are thinking of cirrhosis of liver has led into all these problems, so there is photosystem connections is there in the rectum, no? That can lead to passing blood in the stool. Yes.
What are the importance of reduced urine output, frothy urine, periorbital? That you have to rule out
nephrotic,
renal cause of abdominal distension, fetal urine. In the context of this liver disease, reduced urine output, what significance?
Hepatorenal syndrome. So proteurine indicates what? Proteinuria. So why there is periorbital puffiness? Periorbital only. To early morning periorbital puffiness is common. Yes, no? In case of renal condition, especially nephrotic syndrome, they will see, they will look for periorbital puffiness. Usually they will complain like that. Yes, why?
Same thing does not happen in cardiac.
Yes, cardiac condition cannot happen.
Why? Because of decreased.
Yes,
yeah.
Other PGs can also. Yes, others.
Why in nephrotic syndrome, periorbital puffiness? Why not in cardiac failure? Correct. In cardiac failure, it's increased hydrostatic failure.
So why it is in the early morning only? They say after getting from the sleep, they will have usually in the daytime if they sleep, that time also when they get up, that time there will be facial puffiness, or else early morning they will have. Why?
Gravity, because they come in position.
Yeah, one is that. Any other reasons? Once a person starts sleeping, what are the changes are going to happen? What will happen to the sympathetic activity? What will happen to the vessels? Vasodilation, vasodilatation, leaking of fluid across the capillaries into the interstitial space. That's why they say early morning facial puffiness. Okay. Where are the loose areolar tissues present other than the periorbital region? Where else you can find like this? Periorbital puffiness like that, other areas. Where else you can find? Where else you can find a fluid accumulation?
Dependent areas.
So abdominal wall also. Abdominal also has got a lot of, especially dermal tissue, subcutaneous tissue, dermal tissue has got loose areolar tissue. There also you can find fluid accumulation. Yes.
Business in the context of here, alcoholic liver disease. Not always you can correlate. Breathlessness.
Hepatic hydrothorax.
Any other way?
Or
as you are told, 6 months. Couple disease, cardia and also liver. Huh? But there is no history of breathlessness. That's why I can't think of. Usually it causes DCM and also restrictive cardiomyopathy. Both can happen with alcoholism. So, but here there is no history of breathlessness. That's why I can't think of. There is left side chambers involvement. So cardiac is unlikely. Yes.
Also, there will be pushing up of the diaphragm when there is ascites.
They can have orthopnea also.
Yes.
Because of pushing up of diaphragm. What is platypnea?
Platypnea literally means flat breathing. Patient would feel breathless on sitting up or standing. They'll feel.
What is the mechanism? Here is hepatopulmonary syndrome.
Yeah. Platypnea.
Usually it occurs in hepatopulmonary syndrome. That overcast also.
Orthodeax.
Why? Why standing position makes them breathless?
Right shunting.
What happens to where are the shunts open?
Left to right shunt.
No, not left to right.
Right to left.
Shunt will open up at the base of the lungs.
Which part of the lung? Yes.
Base of the lung. So when they stand up, blood supply goes more to the bases, to the gravity, which it doesn't get oxygenated. So they feel breathless. Same thing can happen in other lung conditions where basal areas are involved. Bilateral basal bronchiectasis or some other pathology in the bases. AV shunts in the bases. So it's not specific only for this.
What is the native medications? What are the native medications which are going to cause liver injury?
Some Ayurvedic medication are known to cause.
Any other allopathic medicines can cause liver injury. What about methotrexate, methyl dopa?
ATT. No other comorbidities in the past. Okay, so past history for this for similar complaints, was admitted in an outside hospital and treated symptomatically. No history of TB in the past. No significant past medical or surgical history. Alcohol history is significant. Consumes around 270 ml of whiskey per day.
What is the serogenic dose of alcohol?
In males, it is 40 to 80 grams per day. In females, 20 to 40 grams.
How alcohol causes liver injury?
So there is increased reactive oxygen species causes primitive micronodular cirrhosis.
How? What is the mechanism? What is the pathophysiology of cirrhosis? Cirrhosis in cases of
Zone 3 hypoxia, centilocular hypoxia.
What are the 3 stages?
Fatty liver, and then alcoholic hepatitis, and cirrhosis. It heals by scar formation, fibrosis.
Is it due to so aldehyde adducts, incompletely digested aldehyde adducts, singlet action, superoxide radicals, and also cytochrome E2 mediated injury to the liver parenchyma with associated lot of inflammation that is going to cause injury to the liver parenchyma than the alcohol itself. Yes.
Would they happen sequentially like that, or can there be overlap? Simultaneously, all 3 pathologies can be coexisting. In a slide, it's not a tight compartment. After fatty liver, hepatitis comes, and then cirrhosis comes, not like that. Maybe simultaneous pathological process can go on.
What percentage of fatty liver goes into cirrhosis? All fatty liver goes into cirrhosis?
10 to 15%.
10 to 15%. Is there any smoking which adds the risk for the cirrhosis in alcoholics? Will it add the risk into the cirrhosis in case of alcoholics? Smoking associated alcohol, will it additive effect? Will there be additive effect on the cirrhosis of liver? Yes, definitely it is there. So person is a smoker along with alcohol intake, definitely it adds into faster injury. Instead of taking 10 years, they will get cirrhosis in 5 to 8 years, like that. Early, 2-3 years early, they will get the cirrhosis.
History. Father died at the age of 40 because of some heart disease. Mother died of 60 because of some respiratory. Significant. Examination.
So what's your final diagnosis?
This level, decompensated chronic liver disease. Probably secondary to alcohol, not in hepatic encephalopathy. Also,
you said that chronic liver disease, once again we came back to same thing, fatty liver. Yeah, or else is it steatosis or is it cirrhosis? Which among these 3 conditions, which one will presents like this? Distension, swelling of limbs and all. Cirrhosis. Then why can't you say cirrhosis? Yes.
Cirrhosis.
Yes.
So what are the signs of decompensation or symptoms?
In this patient, there is jaundice and ascites. In addition, kind of variceal bleed or encephalopathy. Should not seen in this patient. General physical examination. Patient is conscious, cooperative, and oriented time, place, and person. He's moderately built, obese. Weight is 97 kgs and his height was 163 centimeters. BMI is 36 kg.
BMI should not calculate. There is edematis. It's a false value. Don't calculate BMI. The patient is edematis. Ascites.
How do you calculate dry weight in the presence of ascites? Yes. Any form? Total weight minus? Yes. Depends on the. So only anasarca. So just swelling of limbs. So ascites plus swelling of limbs, like that, they will minus. So just pedal edema is there, minus 10%. Pedal edema plus ascites is there, 15%. So anasarca is there, 20%. They will minus.
There is bilateral mild pitting pedal edema up to the ankle. There's ictus. There's no pallor, cyanosis, clubbing, or lymphadenopathy. Our tongue is bald, coated, and moist, and there's a tattoo seen over the right forearm. Respiratory signs of liver cell failure. There are 3 spider nevi seen over the back. There's no alopecia, parotid enlargement, fetal hepaticus, gynecomastia, duplicitans, contracture, palmar erythema, respiratory. No
Tattoos are piercing, piercing one or
Piercing.
non-piercing. So can you suspect, can you link here tattoos?
Hepatitis B.
So
But it's taken some 10 years ago at some local. There could be some exposure to hepatitis.
No, NASA fair, where is it significant? Is it on skull fair or other parts of the body?
Secondary section. Beard, axillary pubic hair.
But usually most of the students, they don't examine for these things. Just, like spontaneously they mention no alopecia like that. But it is very important to look into these signs. And also icterus, by just looking at the clinical sign, is it possible to differentiate like whether it is due to hepatic cholestasis or
Actually, lemon yellow icterus is pre-hemolytic. So lemon yellow. Dark yellow usually seen with obstructive. And if it's like chronic, it will be greenish yellow. It's better to color.
Even if you add alopecia, it doesn't carry much significance. Because normally also without liver dye also many people become bald. Other areas you have to pubic hair, axillary areas.
where do you see spider nevi normally in case of cirrhosis?
So front of chest, back of chest, the upper arms. Not seen below the.
They say in the supraventricular distribution. Any reason is there? Yes.
Pressure gradient.
Pressure.
how do you examine patient?
Slide or pinhead. We usually put pressure over the. Usually, there's a central arterial with the rounding. It looks like a spider. So when you give pressure, it should blanch. When you release the pressure, it will again fill.
How will be the filling? Is it centripetal or centrifugal?
From the center outwards.
So what is that called? Centrifugal or centripetal? Centrifugal.
Fugals.
What are the closed DDs for spider nevi? De Morgan spot.
De Morgan spot. Yeah.
Campbell De Morgan spot. Then what is venous star?
So it's because of a dilated, like small venules will be dilated.
They are found in lower limbs and feet. It's not in the upper part of the body. Supraventricular distribution will find spider nevus, but lower part you'll find venous star. Venous star will be more than 2 centimeters size most of the time. So here it will be less than 2 centimeters. So that's how we differentiate, and also filling also from the so center to away. That is centrifugal. Okay, so that's how we differentiate.
Vital signs: pulse was 84 beats a minute. It was regular, high volume, normal character, no normal condition of vessel one. There was no radial or radiofemoral delay. None of the peripheral pulses were felt. BP was 120/70 millimeters of mercury, measured in the right arm in supine position. Saturation at room air is 98%. Respiratory rate was 17 cycles a minute. It's abdominal thoracic, and there's no usage of accessory muscles. The jugular venous pulse was measured, visualized 4 centimeters above the sternal angle with patient in 45 degrees position. And abdominal jugular reflex was positive but unsustained.
So how do you do abdominal reflex?
Give pressure over the liver for about 30 seconds. Then you see for increase in JVP. In right heart failure, it will be sustained.
How long it persists after pissing? Normally.
For more than 30 seconds.
More than 20 seconds. Rises how much? 3 to 4 centimeter above the sternal angle. Arm rises and it persists for up to 20 seconds. Even if you keep pressing on the abdomen normally. It persists, so up to 20 seconds afterwards it disappears normally. But in case of right heart dysfunction, it will persist.
But what was the need to do that here? When you already could see the JVP, what was the need?
To roll out Pachari syndrome, even if you give pressure, they will abdominal jugular reflex is absent only in Pachari syndrome. Likely.
But here it's abdominal jugular reflex is positive telling. So it means there is something, I think cardiac component is also there. It's what? Yes or no? Because the history is also not actually so directly fitting into the liver. So it's there is confusing history, mixed. So we have to think of some associated cardiac also. Yes or no?
Oral cavity, oral hygiene is fair. There was no missing dentition. Tongue was bald, voice and coated. There are no oral ulcers, no fetal hepaticus or halitosis. Abdomen inspection. The abdomen appears uniformly distended and flanks appear full. The umbilicus is transverse slit-like concavity downwards, appear to be displaced downwards. All corresponding quadrants move equally with respiration. There's a paracentesis scar seen over both sides of the abdomen.
See, ascites, is the cause for abdominal distillation. So, we differentiate by inspection. Is it due to ascites versus other cause for abdominal distillation?
Usually, ascites will be like uniformly distended. Any other causes?
See, you told some, yes, fluid of fetus, ficus, something and all you told now. How to differentiate fluid versus all other causes in inspection?
Male patients of fetus is unlikely.
No. So, okay, yes. You tell about other things. Then what are the causes for diffuse distillation of abdomen?
Lattice.
Lattice means what is the cause you tell? Only is ascites. Mnemonic is for your memory. What are the causes for diffuse distension of abdomen?
Ascites,
One
fat,
is
obesity. These patients can have.
you come out of that in the normal physiological. We don't want so that may be pathological, but here, with respect to this case, we tell. What are the causes? One is ascites. Next, so in case of large bowel obstruction, there can be diffuse distension. Next, in case of retroperitoneal tumors, yes, now retroperitoneal mass it can cause, or else renal mass, huge atrial pushing all the coils one side, kidney one side, it can cause diffuse distension. And in case of female, it is pelvic tumors. Yes, now to differentiate from all these conditions versus ascites. So what will happen to the flanks in case of ascites?
Flanks will be full in ascites.
Yeah, flanks will be full in ascites. In remaining all conditions, flanks will be free. That's the point. And also, umbilicus is transversely stretched in case of ascites. Other conditions, it may be, depends. In pelvic tumors, it will be vertically stretched. Flanks will be free in that condition. Yes. Okay.
How do you differentiate ascites from full bladder?
After you ask the patient to block voids, after voiding, if it's still distended.
We are unable to void. That's why matters got displayed.
What is horseshoe shaped dullness?
Because of air in the bowel, like there'll be like a horseshoe shape. Basically the bowel floats up and the fluid is around it. So when you percuss, there's like a horseshoe shaped dullness around. Centrally there'll be like resonant tympanic, and around that will be like a dullness.
So in bladder distension, it won't be horseshoe shaped.
Horseshoe shape.
Okay, and even the desiccation to umbilicus distance and symphysis equals to umbilical distance. So that will be different. Bladder distension versus ascites. From ovarian cyst, how do you differentiate ascites?
Ovarian cyst, if it's like usually it's unilateral, one side will appear.
One side will appear.
The umbilicus to pelvic symphysis distance versus umbilicus to episteme.
The lower this thing will increase. So pubic symphysis umbilicus will be more than the umbilicus to episteme.
What is Meek syndrome?
Ovarian tumor causing left-sided.
Left side.
Right side.
Along with ascites.
Ascites in the right side of the palpation, superficial palpation, there was no localized temperature, no tenderness, and no guarding or rigidity. Deep palpation, liver is not palpable, no hepatomegaly. Spleen is just palpable below the left costal margin. It was not.
In inspection, have you seen this one, extended tally? Scrotum.
Separately.
Scrotum. That is also component of inspection. Scrotal edema is there.
Scrotal edema is there.
What it indicates scrotal edema? Ascites is there, scrotal edema is there. What it indicates? So there is definitely, actually, so it can't be other than fluid. So same thing, which is there is a connection is there between the scrotum to abdominal wall. The ascitic cavity. Yes, that's why that means fluid which just leak into that part.
Examination of the external genitalia constitutes 1% of the examination of the abdomen.
There's no other palpable mass. The hernial orifices were normal. Abdominal girth was 114 centimeters at the level of the umbilicus. Spino-umbilical distance was 22 centimeters on both sides. Xiphysum to umbilicus was 24 and umbilicus to pubic symphysis was 16 centimeters. The ratio is 1.5. And percussion, the upper border of liver dullness is fed in the right swift intercostal space in the midlateral vein. Spleen drop space was dull. At Castell's point, there was no dullness. And the shift in dullness was demonstrated. There was no fluid.
Upper border of liver dullness, is it going to give any information here? Is it
Lower border, we could not feel.
drop space dull? So much of ascites is there. Still, you want to percuss drop space. Is it works here? Is it required? Is it going to give any extra information? What is Castell's sign?
Castell's point is
Castell's sign. That is also, I think, it's not going to give any information because there is ascites. First, tell us what is Castell's.
It's a method of percussion of the spleen.
Yes.
In the anterior axillary line in the 9th intercostal space. We percuss if it's dull, it's probably because of spleen. Which is
The anti-axial line in the 9th and 10th intercostal space. If you percuss, you will get the dull note in case of splenomegaly. What is Dixon's sign?
Nixon's sign.
Nixon's method. Okay, yes.
It's in the posterior axillary. You start percussing from upwards downwards, you'll feel the resonance of the lung. At the point where the resonance is lost and it becomes dull, you start percussing along the long axis of spleen. And you,
For Nixon's method.
Nixon's method.
Position of the patient.
right lateral.
Right lateral position.
Right lateral, and start percussing from upwards downwards. At one point, you'll feel a level of
Where exactly?
Particularly from the costal margin in the midpoint. Okay, it is a method to detect the mild splenomegaly. Why you want to see there actually? What is the way the spleen enlarges? It enlarges first posterior superior, then it starts downwards
towards the right.
Yeah, so in the initial part only you can detect splenomegaly.
Where do we get ascites but no shifting dullness?
In massive ascites.
10 centimeters.
10 centimeters.
Any other?
Calculated a minimal. What is it? Auscultation bowel sounds 3 per minute. There's no brewy venous hum or any problem. External criteria, there was scrotal edema. I think there was no tenderness. This was normal and testicular sensation is present. Testicular. Other systems, cardiovascular, as well as was heard, there are no murmurs. Respiratory system, bilateral normal vesicular breath sound. Normal intensity of breath sounds are heard in all areas. There were no added sounds. And CNS, high metal functions are intact. Cranial nerves are intact. Motor system is normal. Deep brain reflexes are 2+. Bilateral plantar are flexed. Sensory was normal. No cerebellar signs. No meningeal signs. No flapping tremors. So, for cephalopathy. Left is mind, right is a patient.
What is constructional effect here?
Usually non-dominant parietal lobe movement. They'll find it difficult to draw like a clock or a star to replicate it.
What is it exactly? How do you test that construction of taxa?
Retails numbers.
25 dots.
What about intersecting polygon?
Yes.
Intersecting polygon. See, they can't connect that in intersecting. Polygons, they can't intersect.
Final diagnosis. Decompensated chronic liver disease, cirrhosis, evidence of portal hypertension, with no evidence of hepatic encephalopathy, spontaneous bilateral peritonitis, or upper GA bleed, right lower limb cellulitis, and obesity.
Is it diabetic?
What has caused decompensation? All this has happened since 15 days.
Either right lower limb cellulitis.
Jaundice has developed since 15 days.
Jaundice since 15 days. Ascites since 15 days, but lower limb swelling since.
Thank you.
What would have aggravated is the decompensation? What would have aggravated decompensation?
Can you tell some factors?
Is it due to infection here? Infection, right? As you're telling, right, lower limb cellulitis is there. Okay, what are other causes for decompensation?
Patient continues to take alcohol. Alcohol binge.
Yeah, continues to take alcohol. Yes, binging. Yes, next.
Upper GA bleed.
Yes, GA bleed. Yes, next.
Any infections or other causes.
Okay. Yes, BP. Next. What about diuresis? Large volume paracentesis.
Large volume.
Yes, next. And diuretics also. If patient has got hypokalemia because of diuretic induced, they can have aggravation of encephalopathy, not the liver cell failures.
Alkalosis.
So what next? How do you evaluate this case?
Get routine investigations like complete hemogram, RFT, LFT, urine routine, ultrasound abdomen, PTNR, ultrasound abdomen pelvis, and once in 6 months endoscopy.
What do you look for in ultrasound abdomen?
Liver size.
Yes.
Echo texture, mucosal.
Yes.
If you look for clinically, there's no hepatomegaly, whether that is correlating liver size and portal vein diameter, spleen size, and whether myositis is there.
When do you say portal hypertension is present?
More than 10 millimeters.
More
Pressure is
than
less than 10.
Less
More
than 10.
is portal hypertension, more than 12 likely to have.
Sometimes other conditions also we can rule out, like lymph nodes if they are there, so we can rule out tuberculosis also. So nothing prevents this patient to have tuberculosis also. Yes, no. In chronic cirrhosis patients, they can turn into HCC also. Yes, no. That also we can pick up if there is on liver mass or any lymph nodes, portal vein size. All that actually so we'll get in and also quantify the ascites also. Yes, these are the things we can pick up in ultrasound. What are other tests you do specific to this case, liver? So do you want to go for ascitic fluid analysis?
Diagnostic analysis to report SPP. And confirm whether it's high sag or low sag.
Yes. Any other tests?
GA endoscope.
For what reason?
Variceal bleed.
Variceal bleed. Then varices. So why do you want to look for that varices? It may be one of the complications of cirrhosis. So patient has to, that also again confirms that patient has gone into portal hypertension. Yes, no? And at the same time, they can intervene. Yes, if varices is there, they can intervene and they can prevent sudden death because of massive hematemesis. Yes. Any other tests?
Alcoholic. We haven't really ruled out cardiac, so ECG echo.
And you want to get the LFT, no? You forgot to get LFT. So there will be protein deficiency, So in such patients, you have to supplement the protein. Cirrhosis of liver, you have to give extra protein. Instead of 0.9 gram or 1 gram, you have to give double, or 1.5 times. Yes, no?
Which are the scoring systems you do for prognosis of this patient?
Child.
What are the parameters in childbirth?
Bilirubin, INR, albumin levels, encephalopathy, and ascites.
MELD score? What are the components? MELD score.
It's MELD and MELD sodium. Sodium levels.
MELD. Child fix is what you are told. MELD score. That is for liver transplantation you consider. One is creatinine. Next.
INR.
Then albumin. Albumin what?
Encephalopathy.
Encephalopathy. Yes.
Any questions from other postgraduates?
What is the treatment you will do here?
So for portal hypertension, we give beta blockers, actually carvedil also. Yes. And we have to put the patient on diuretics. Also have to monitor RFT once.
Which is the most important treatment here? First one is salt restriction. So without salt restriction, without fluid restriction, whatever you do will not work. How much of salt restriction is it? Less than 6 grams. Yes, fluid restriction. In case of anasarca, it is less than 750 ml. In case of just lower limb swelling, it is 1250 ml. Lower limb plus ascites, it is 1000 ml. Anasarca, you have to restrict to 750 to 800 ml. That much of fluid should be restricted to that much of fluid along with that salt restriction. Next, you should add diuretics. In the diuretics, you have to give classics and also pyrazinamide and also. So, what is large volume paracentesis?
More than 1.
More than 1 liter. What is large volume?
What is dynamic paracentesis?
Giving albumin same time as like you give something.
When do you do that usually?
If you're anticipating hepatic encephalopathy.
More than 3 liters of ascitic fluid, there is a likely chance that patient can go for hypotension. So you have to replace the albumin.
How much of albumin you should give for 1 liter in water?
And get the question.
How much of albumin you should infuse or 1 liter fluid removal, 1 liter of CT fluid removal. No, how much of albumin total? How many grams? 8 grams. Okay, 5 to 8 grams of albumin you should give for every liter fluid from the acetic cavity. Yes. So what is the ultimate treatment here? Liver transplant. Yes. What about the tips? Other methods are there, so how they help here? What is the role of tips here? Have you heard of tips? What? Yeah. Trans, venous, intra, hepatic, portosystemic connections. Yes. So what is the role of tips here? Is the bridging therapy before subjecting this patient for liver transplantation? What is the survival rate with liver transplantation? It's 90%. 10 years is 65%.
ಔಟ್ಪುಟ್ ತೋರಿಸ್ತಾ ಟೆಸ್ಟ್
Good presentation.
Patient chairpersons. I request Dr. BG sir to kindly hand over a token of gratitude.
ಇಲ್ಲ ಆನಾಗಿದೆ 5 ನಿಮಿಷ ಟೈಮ್ ಕೊಡಿ ಸರ್ ಎಲ್ಲ ಆಫ್ ಮಾಡಿದ್ರು ಅಂದ್ರೆ ಅಲ್ಲಿ ಆನಾಗಿದೆ ನೋಡಿ ಕ್ಯಾಮ್ರಾ ಅಲ್ಲಿ ಹಿಂದೆ ತಗೊಂಡಿದ್ದೆ ನೋಡಿ ಗ್ರೀನ್ ಲೈಟ್ ಗೊತ್ತಾಯ್ತಾ ಎರಡಲ್ಲವೇ ಪ್ರೊಸೆಸರ್ ಹೆಂಗೈತೆ നല്ല ಕೊಡ ಬೇಡ
The results of the case discussion will be announced now by Dr. Srinath K. sir.
Well, if you come tomorrow at 8:15, have breakfast and sharp 9 o'clock, we'll start the program. Okay. Finally, we have come to the end of today's session. The first prize goes to Dr. Sharan Prasad from MMC. I request BC sir hand over cash prize as well as oh, don't worry, other two students have also done very well. So they also get the consolation prize. Dr. Kavya Agarwal. Well done, Kavya. Keep it up. Now I call upon Dr. Rupesh. This is also done nicely. Actually, I was jokingly talking to BG sir. He was very good. After going to DRP, he has become a little bit dull. I don't know why. All these students are becoming like this. After going to DRP, coming back from DRP questions, they are forgetting some clinical medicine. Thank you, Ananda. Tomorrow, as usual, we'll have a presentation, various case presentations and other things. So please be come at 8 o'clock only there. Breakfast will be served at 8 o'clock only. Be at 8 o'clock only so that you can be ready at 9 o'clock presentations. So we're going to start the presentations at 9 o'clock sharp. Thank you, one and all.
ಹುಷಾರು ನಿಮ್ದು ವೈರ್ಗಳೆಲ್ಲ ತಗೊಂಡು
ಮತ್ತೆ ನಾಳೆ 2 ಗಂಟೆ ಏನ್ ಬೇಡ ಲೈವ್ ನಿಮ್ಗೆ 2 ಗಂಟೆಗೆ
ಇಲ್ಲೇ ಇಡದ ಏನು
ಇಲ್ಲೇ ಇಡೋಣ ಇನ್ನೇನ್ ತಗೊಂಡೋಗಿ
ಇಲ್ಲೇ ಅಡಿಲೇ ಇಟ್ಬಿಡೋಣ
ಆಡಿಯೋ
ಏಂದ
ಇಲ್ಲ ಸಿಸ್ಟಮ್
ನಮ್ದೆಲ್ಲ ಇಲ್ಲೇ
ನಡಿ ನಾನು ಅರ್ಜೆಂಟ್ ಸುದ್ದಿ ಬರೀಬೇಕು ಟೈಮ್ ನೋಡಿ ಸುದ್ದಿ ಬರಿಬೇಕು ಎಲ್ಲಿ ಸಿಕ್ಕಿಲ್ಲ ಇಲ್ಲ ಅಂತ
ಬರೆಯೋಣ ಈಗಲೇ ಕುತ್ಕೊಂಡು ತಗೋಣ ಪೆನ್ ಬೇಕಣ ಪೆನ್ಸಿಲ್ ಬೇಕಣ ಏನ್ ಬೇಕಣ್ಣ ಕೊಡಿಸ್ತೀನಿ
ಅದೇ
Yeah.